And good morning.
Good morning, everyone. I would like to introduce Melissa Jackson Morse, Executive Director of Cornerstone Community Association, to present the 2024 year-end organizational report for Cornerstone. Melissa has been with Cornerstone since 2016 and has served a variety of roles, including community service worker, outreach manager, and program director before stepping into her leadership role. She brings a strong background of both social work and senior management. Cornerstone is also part of our homelessness system and our continuum of care. So I'd like to introduce and bring to the podium Melissa.
Thank you, Sahar, and good morning to everyone. And thank you for the opportunity to present this information this morning. I will be reviewing Cornerstone Community Association Organizational 2024 Year-End Report. The full report is available upon request. Cornerstone Community Association has been serving the homeless in Durham since 1967. Our emergency shelter program ended the year with an occupancy rate of 92.48%. The shelter program supported 655 guests. 440 of these guests were first-time shelter users. Some contributing factors captured in 2024 around the reason for service are as follow. 43.7% was due to relationship breakdown or lack of family support. 39.17% was due to financial crisis. 35.28% was due to mental health. 32.6% was due to lack of affordable housing, and 25.6% was due to substance use. Our emergency family shelter program had an average caseload of 11.41 monthly. 25 families were housed in 2024. The family motel program supported 57 children. An average length of stay was approximately 89.6 days. The senior motel program intake increased in 2024 by 54.48%. Average caseload in that program was 13 per month. Average length of stay, 93.45, and 15 seniors were housed in 2024. In 2024, our Bridges Street outreach supported 111 individuals to access various forms of housing, treatment, and supportive housing. Anecdotal evidence showed that approximately 15 to 20% of individuals supported in 2024 required access to a supportive living environment that was beyond the scope of a traditional transitional living environment due to their unique needs. In 2024, 15 individuals accessed the Redemption House of Recovery pre-treatment program. 8 individuals accessed treatment and entered into a post-treatment program. Our 178 Athol Street Transitional Program, this program has 9 rooms and is a year in duration. Participants take place in daily programming. Some examples of these programs offered are art therapy, Fitness Friday, Motivational Mondays, financial literacy workshops, creating healthy habits, general clean day, access to a psychologist, and addiction workshops every Friday afternoon. This program has 24-hour staff support. There were 7 graduates in 2024. All graduates successfully transitioned into permanent housing. 2 of those graduates secured employment. And the picture on the screen is a zine that was created by the participants at the 178 Athol Street Transitional Program during couple sessions of art therapy in 2024. This artwork is displayed at our 121 Simcoe Street building. Our Housing First program had a recidivism rate of 5% in 2024. Number of home visits in 2024 was 1,065. Our community residential facility had 26 graduates in 2024. 162 cases were referred and 65 cases were accepted. Our occupancy rate in that program in 2024 was 96%. Our internal housing program, understanding that the organization supports the Heart to House, there were 4 evictions in 2024. These 4 evictions range from extreme hoarding, drug trafficking, arrears, and violence. These individuals were provided with referrals and support during their transition. The housing support team assists tenants in managing and maintaining their life skills activities. These supports include, but are not limited to, financial management, grocery shopping trips, monthly tenant meetings, recreational activities, tenant workshops, and referrals to community supports. Our internal housing program has 88 units, and we ended the year in 2024 with an occupancy of 79%. Our aftercare community program conducted 658 home visits. The satisfaction rating was 89%. 3 individuals were rehoused. There was 9 preventions, 0% return to homelessness rate, 12 community recreational outings, and 24 workshops. Our housing benefit program, in 2024, there was a 100% success rate. Individuals and families that received this portable housing benefit maintained their housing throughout 2024. Our community kitchen program, this program basically held 24 classes with a total of 31 consistent participants. These cooking classes assist individuals to prepare meals with various food items, including items that were provided by local food banks. The 178 Athol Street Transitional Program held 48 cooking classes. These classes are an integral part of the programming that equips individuals with the necessary skills for preparing healthy meals. The program participants acquire skills that are transferable upon graduation. These skills are also employable skills that are useful within the culinary sector. Our food services program prepared and served 76,788 meals and 18,600 snacks within the shelter program in 2024. Our organization hosts 2 community events annually. The picture on the screen is our community barbecue and our holiday brunch that is normally held just before the holiday season. Thank you for the opportunity to present today.
And thank you. Mayor Carter first.
First of all, good morning, Madam Chair. Thank you very much. Well, it's great to be able to see you once again, and thank you for meeting with myself and our senior leadership team on April the 29th. I'm going to start from the back, if that's okay with you.
Certainly.
The food services program, 76,788 meals. That's about 210 meals per day. Is that outside of the amount of residents you have within the building, or is that 3 meals a day, or is that 2 meals a day?
Yes, so that's a good question. So it's 3 meals a day with a snack.
Okay, all right. So the 76,788 is all total?
Correct.
Oh, okay,
In
good.
total.
That's a lot of meals.
It
That's
is.
a lot of meals. So well done by your, how did you, the classes that you held, you had 31 individuals. Was that to help them with their life skills?
So yes, so what we do is we do have our community cooking program. So that program is basically designed to support individuals to enter back into the workforce. So at the end of that 10-week curriculum, individuals would then be supported with applying for their food handler certification.
That's great. So that gives them an opportunity to be able to seek employment and opportunity. Do you have an employment component to your services at Cornerstone?
We do. We do have some local agencies that work with us.
Oh, that's good. So that's wonderful. The community outreach, 658 home visits. Do you have 2 individuals that do those? Is how many individuals? And are these prior clients, 658?
Yes, so that's our community aftercare program. So these
Yeah.
are clients that have graduated from our Housing First program, where there's intense case management. So what we have recognized along the way is once these individuals graduate from our Housing First program, the likelihood of individuals re-entering homelessness was high. So we created this team that's called the aftercare team that provides low to moderate support. So they do taxes, they assist if there's landlord and tenant board issues. They do food bank trips. They do recreational activities. So it's about forming community and being a support for
Good.
these individuals.
Great stuff. Your internal housing program, and you broke it down in regards to your locations, but you go 0 to 1 year, 1 to 4, 3 to 9. These are number of years that they're tenants of yours. Is that correct?
That's correct.
So it looks like that kind of the really important part is about 1 to 4 years.
That's correct.
So that gives them the opportunity to be able to get the life skills, get back on their feet, maybe deal with their mental health or addiction, get into a place where they're strong enough for independence. Is that a fair assumption?
That's a fair assessment.
Okay. And it's rare that you have people for really long stays, 20 to 25 years, 7%. And then, of course, 25 or more is about 2%. But it seems like that 1 to 4 is really, that's a vital place for success of individuals that are trying to rebuild their life.
Yes.
Yeah. Okay. That's fantastic.
And if I may add
Yeah.
on our internal housing program, it wasn't highlighted in this report, but we do have 10 supportive living units.
Yeah.
So those individuals are attached to a tenancy, but they are prepared with meals daily as well. So they're more of a supportive unit within that housing.
Where's that?
So we do have those units located at our 133 Simcoe Street building.
Okay. All right. So that's good to know that those are there. I want to talk about your senior motel program intakes. You said it increased by almost 55%.
Yes.
Did you find out what the reasoning behind that was? And was it total cases per month were 13? So does that mean that it was about 6 last year and now it's increased to about 13?
Yes, approximately. So some of the major contributing factors we've recognized in 2024 was mostly around affordability.
Right.
Unfortunately, some of the seniors that enter the program, their spouse must have passed on and they're unable to afford rent. Also, there's a term that has been used quite a lot last year with reno-evictions, so individuals were being evicted. So those were some of the prime reasons. Also, we have seen a high number of individuals with dementia as well. So that's all those contributed to homelessness.
Melissa, did you break it down male or female out of those 13 per month?
I do have those numbers, but I
Okay.
would tell you that it's a higher percentage of male.
It is.
Yes.
Is there a reason behind that?
I can get back to you with that, but yes.
It's a question I always ask because even when we look at our unsheltered population or those that are suffering with addiction or mental health, it seems like the percentage of males outpaces females, and I'm trying to figure out why that is. So that's the reason why I asked that. The average length of stay for your seniors is almost 94 days. That's a long time.
It is.
That is. What's the cost per day? Do you know?
So it ranges, the hotels, we do have, a structure set up with the hotels that we do not pay their regular rate. So
Right.
it could run us maybe approximately $100.
$100. Okay, so all right, so that's good to know on that. The shelter program supported 655 individuals, but 440 were first-time shelter users. Is that correct?
That's correct.
Okay, and out of those 440 that were first-time shelter users, what was the geographic area they came from?
So it varies. I would say the highest percentages came from the Durham region, but we do have individuals that are very transient. That comes from various parts of Ontario. But I would tell you the highest percentage came from the Durham region.
And do you have a breakdown of the Durham region in regards to where their place of origin is?
I do have that breakdown, but
Okay.
not with me right now. But I can.
Could
always
you
get
share
it.
that with us, if you don't mind?
Oh, certainly, I can
Yeah,
send an
when
email.
you have an opportunity, I greatly appreciate it. It's about 60% are associated with mental health and substance use, but the family relation breakdown is about 43% on your chart. Financial crisis is about 40%, and then of course lack of affordable housing is 32%. You and I met on April the 29th. Where do you get your funding from?
We got our funding from the Durham region.
Okay, and with Durham region, can you share with us what that number is?
In terms of total funding,
Yeah.
it's approximately about 3.7.
$3.7 million?
Correct.
Okay. And is there a policy that goes with that in regards to the funding? Is there a requirement by the region in regards to what is expected in regards to the $3.7 million? I'm not talking about allocation of dollars, but is there a framework that the policy must follow?
Well, we would have to fall in line with operate, I would say, within the confines of the MOU.
Right. Has there been any changes in your funding agreement over the last little while from the region?
In terms of, if you could be a bit more
Your
specific.
intake process?
Well, I would say back in 2023, potentially, we would no longer just support individuals within the Durham region. I'm not sure if that's your question.
Yeah.
Yes.
So was that requirement removed by the region? Was it, or did the region say you now have to provide services for anyone that shows up on your doorstep and not prioritize individuals from Durham region?
Well, so to answer that question, due to the asylum seeker situation that took place I think in all of Ontario, that was something that was mentioned.
Do you have, and I know that many of us are aware, we had an individual that ended up on your doorsteps, and matter of fact, I think was sent there from a release program that was a dangerous offender, and you had to make a decision that that individual would not be able to find shelter within your location. Is that correct?
That's correct.
Right. And that you made that decision because of the reason that you believe that you have a responsibility to all those that are in your facility. Is that correct?
That's correct.
Okay. So you have that authority to be able to do that at the appropriate time. Is that correct?
That's correct.
Is there, there's rules and regulations about staying at your facility, I presume?
Are you referring to code of conduct?
Yes.
Yes, we do.
Okay. Drug use allowed at your facility?
No, we don't allow drug use.
Weapons allowed to be in your facility?
No.
What, especially with your facility, your facility is more of a dormitory style, is it? Is
It
it a
is.
more dormitory style?
It is.
Have you looked at modernization of your facility?
That's something that we are exploring right now.
Okay. And how long have you been exploring the modernization of your building?
I would say it started prior to me being in this position. I would say approximately, if I'm correct, approximately maybe 3 to 4 years ago. This was a discussion.
Okay. And when you think about modernization, is that going from a dormitory style to a different type of style?
Yes, I would say that we currently have 40 shelter beds, and our seating for dining is only 20. So
Right.
looking at, expanding the space, having a space for recreational use as well, and also potentially having something like an infirmary. So if someone is ill,
Yeah.
that there's an area they can isolate.
Would you go to single rooms or single occupancy or double occupancy within a room or something?
I think it all depends on the square footage that we do have available.
Yeah.
I think that would be the main factor.
Okay. Is dormitory the best practice, even in today's environment?
That's a tricky question. I want to say yes, and I want to say no. I've
You can
never.
say both.
Yeah. So that would be my answer. Yes and
Okay.
no. Yeah.
All right. When do you think that you might be able to come back and tell us about a modernization plan of your facility?
I would be able to maybe at the end of the year, because we're working on
Beautiful.
Submitting some applications for funding. So
Yeah.
maybe at the end of the year I
That's
can
great.
provide an update.
Melissa, I really appreciate you answering my questions today. I wish you all the best. Thank you to your team for the work you do each and every day. And I look forward to our next conversation.
Thank you.
Madam Chair, that's my questions. Thank you.
Thank you. Is there any questions from committee members before I go to Councillor Kerr? Councillor Kerr.
Thank you, Chair. And through you, pardon my lateness, it was a really bad accident at Roslyn and Thixon. It was lined up for 1.5 kilometers. So I had to use a little creative detouring to get here when I did. So pardon my lateness, please. I may have missed something, but my only question is a follow-up to Mayor Carter's question, when you had a yes and no answer, would you kindly elaborate on why it's a yes answer and why it's a no answer, please?
Certainly. So in terms of the dormitory style, we do conduct half-an-hour rounds, right? And from a staff perspective and from a visualizations perspective, I think it may be easier if there's dorms. My concern is because of right now, because of the high level of drug use that is taking place in the community, if individuals are in, let's say, single units, my concern would be not having that visual on the individual if that person was to go into an overdose. Normally, right now with the dormitory style, if a staff is not present, one of the guests will come to staff to say, hey, this gentleman on this particular bed seems unwell, and then we can go in and support the individual. So that would be my only concern.
Is there a concern in a shared occupancy of PTSD amongst the people being in a room with other people, or is there a risk of contraband drugs being brought in and shared amongst people in a dormitory situation as opposed to single rooms?
And again, that's a valid point, and that's why my answer is either yes or no. But again, this will all be determined on what available land we do have available before I can actually make that decision. Right now, if we're looking at our expanding our building, we would only have one lot of land to do that expansion on. So again, it all determines on what we do have available and if it is something
Yes.
that is attainable.
And lastly, through you, Madam Chair, when it comes to the meals, you can only serve 20 at a time, but you have 40 some odd there. Do you then just do basically shifts?
Yeah.
Okay, fine, thank you. Thank you very much. Those are my questions.
Thank you. Further questions?
Okay, thank-
Online, any questions? So I want to continue the conversation around the dormitory setting versus like single rooms and completely understand. And so I know that 1635, we have dormitory setting, and the explanation was as such. One, it's that visual as the staff are walking through, and it's also that security component to it. But as an individual is entering into Cornerstone, are they questioned and interviewed for potential of having any paraphernalia on them at that point in time?
Yes, that's part of the intake process.
Each time that they come in?
That's correct.
Okay, all right. Thank you very much. And thank you for bringing the presentation, and look forward to the future of what potentially could happen with Cornerstone as well.
Thank you.
I'm going to call upon Tara Zupanzik, Climate Change and Health Specialist, assessing the impacts of vector-borne disease. And Tara, you're online.
Through you, Madam Chair, and good morning, everyone. As the Climate Change and Health Specialist for the Durham Region Health Department, I'm here once again, this time to share our third vulnerability assessment in the Climate and Health series. This one focused on vector-borne diseases. So I'll briefly once again cover the purpose of the report series in general, and then jump into the findings of the vector-borne disease report. Next slide, please. So why are we doing this work? As you know, the health department is required to assess health vulnerabilities under the Ontario Public Health Standards, and this includes climate-related health risks. And perhaps even more importantly, we know climate change is already affecting the health of residents, health system capacity, as well as disproportionately impacting some people more than others. While many health effects are preventable, and we really want to stress that, a local public health survey shows that many Durham Region residents don't feel personally at risk. So this is why assessing and communicating health risks is so essential to increase awareness, preparedness, and prevention. So as you know, this report series builds on last year's Climate and Health Primer, which identified 6 key climate hazards in Durham Region that serve as the foundation for the 6 vulnerability assessments. Reports on extreme heat, solar UV radiation, and vector-borne disease have been released, and the remaining reports on air quality, extreme weather, and food and water impacts are set for completion this year. Next slide, please. So now let's move to the vector-borne disease or VBD report. Climate change is increasing the number, distribution of disease-carrying vectors, leading to a rise in infections across Durham Region. So this report examines current and future impacts, providing a strategic framework to assess and address VBD vulnerability based on exposure, sensitivity, and adaptive capacity, which I'm sure you're all familiar with by now. As our climate shifts, the spread of Lyme disease and West Nile virus is expanding, putting more residents at risk. So our main objectives of this report are to enhance understanding of VBD health impacts, assess and report on local health data and future risks, prioritize health equity, and establish a baseline for future assessment. And this report also integrates the review guidance and perspectives of the Mississaugas of the Scugog Island First Nation, strengthening both the report itself and our future ability to collaborate on adaptation and prevention strategies. Next slide, please. So warmer and wetter seasons due to climate change are increasing the reproduction, survival rates, as well as the geographic range of disease-carrying ticks and mosquitoes. And this is a trend that's expected to continue. This has led to a growing spread of VBDs in Durham Region, with Lyme disease and West Nile virus disease at the forefront of concern. Lyme disease is among the fastest growing infectious diseases in Canada, with blackleg tick populations now established in all of Durham's local area municipalities. The health burden of Lyme disease in Durham Region continues to rise, even outpacing the provincial average. So this figure here on the right from the report, you can see that over a 10-year period from 2013 to 2022, Lyme disease incidence has followed a steep upward trend. Cases in 2021 were 2 times higher than 2019 and 3 times higher than 2018. Similarly, West Nile disease cases, while low, have increased, surpassing Ontario's average since 2020, with mosquito surveillance confirming ongoing expansion. And then other emerging vector-borne diseases, including anaplasmosis, Powassan virus disease, and babiosis transmitted by ticks, as well as Eastern equine encephalitis and other mosquito-borne diseases are of growing concern. And notably, as of July 1st, 2023, Powassan virus disease, babesiosis, and anaplasmosis have been officially designated as diseases of public health significance in Ontario, which means mandatory reporting is required to local public health authorities. Next slide, please. So in some cases, these diseases are very mild. In other cases, they can result in debilitating illness and disabling neurological conditions, and in very rare cases, death. For example, most people infected with West Nile virus experience no symptoms at all, but others may suffer from fever, body aches, and fatigue. In severe cases, West Nile virus can cause neuroinvasive disease, leading to disorientation, convulsions, and paralysis. While this is rare, emerging research suggests that cases of neuroinvasive West Nile virus disease are expected to rise. So this is why knowledge and awareness of bite prevention, treatment, as well as disease symptom recognition are essential for prevention, early intervention, and disease mitigation. So while there are many actions that can greatly reduce exposure to vector-borne diseases, local data show that the uptake of preventive measures in Durham Region remains very low. Next slide, please. As always, some people face a greater risk of serious health outcomes from VBDs than others. Young children, older adults, pregnant people, Indigenous peoples, and individuals with a weakened immune system overall experience higher risk of complications compared to the general population. So to assess VBD vulnerability, as always, we consider these 3 factors: exposure, sensitivity, and adaptive capacity. So agricultural workers, for example, face higher exposure, while individuals with a compromised immune system are more sensitive. Those lacking shelter, knowledge about insect and arachnid bites, or access to timely health care experience vulnerability due to limited adaptive capacity. So prioritizing equity means addressing the intersection of these vulnerabilities. So as an example, First Nations peoples exercising their harvesting, gathering, and fishing rights experience heightened exposure to VBDs and may also face healthcare access barriers. So strengthening awareness, prevention, and response strategies is essential, especially for those most exposed, most sensitive, and least able to protect themselves. Next slide, please. Okay, so exposure to Lyme disease is highest from May to July and then again from September to November, but these windows are expanding due to warmer seasons. The greatest risk occurs when nymph ticks are active in the spring and adult ticks in the fall. With more winter days above 4 degrees Celsius, tick activity periods are expected to lengthen. And then West Nile virus exposure is typically from June to September with a peak in August. So most cases in Durham region occur in late summer, aligning with mosquito activity. And mosquitoes require temperatures between 14 degrees Celsius and 35 degrees Celsius to develop. And positive pools in Ontario peak in mid to late August, coinciding with these temperatures. As temperatures rise and rainfall increases due to climate change, seasons for disease-carrying vectors will lengthen, leading to population growth and heightened risk. Next slide, please. So despite rising risks, awareness and preventive actions remain low among Durham Region residents. Over 5 years, 80% of reported Lyme disease cases involved individuals who had been in tick-prone areas, yet most did not check for ticks, wear protective clothing, or use insect repellent. Similarly, over a 10-year period, most West Nile virus cases occurred among individuals exposed to mosquitoes, but who had not taken preventive measures. And again, a local public health survey found that fewer than half of adults consistently protect themselves after visiting tick-prone areas, and an overwhelming 90% do not use insect repellent. And Durham Region is not alone in this. Nationwide, uptake of VBD preventive behaviors remains low. However, this does present an opportunity. Increasing awareness and action can significantly reduce infections. So more vectors in the environment does not have to mean more disease, but they do highlight the urgent need for innovative strategies to improve prevention. Next slide, please. So the health department actively monitors, controls, and prevents vector-borne diseases through the Vector-Borne Disease Prevention Plan. This plan aligns with provincial public health standards and is supported by the Durham Region Vector-Borne Disease Response Committee, which includes municipal representatives, conservation authorities, and public health officials. Under the plan, the health department conducts regular mosquito surveillance, site inspections, and environmentally friendly larval control to reduce breeding sites. Active tick monitoring tracks Lyme disease and other emerging tick-borne diseases. And public awareness is also a priority with education campaigns, high-risk area signage, and digital outreach engaging local agencies, outdoor workers, and the broader community. The Mississaugas of Scugog Island provided valuable contributions to this report, including recommendations to integrate Indigenous knowledge, such as traditional ecological terms and collaborative approaches that merge scientific monitoring with Indigenous practices like controlled burns for environmental health. And we recognize that Indigenous knowledge can play a vital role in climate resilience, including vector-borne disease prevention. Next slide, please. So as disease-carrying vectors increase in our communities, how can we strengthen resilience and prevent infections? To begin with, outdoor workers, including utility crews, construction teams, agricultural staff, and emergency responders, all face growing risks from vector-borne diseases like Lyme disease and West Nile virus. With over 10% of Durham Region's workforce operating outdoors, prioritizing safety is essential through specialized training, protective equipment, clear reporting systems, and workplace exposure tracking. But prevention extends beyond workers. Community awareness around Lyme disease and West Nile virus, as we've mentioned, remain low, especially among young adults. And research shows that many cases may have been avoided with proper precautions, underscoring the need for stronger health campaigns, education, and outreach. Some individuals, as we've mentioned, face disproportionate risks to socioeconomic barriers. Older adults, pregnant individuals, Indigenous peoples, and those with a weakened immune system require more targeted support. So direct engagement with priority populations and local organizations that support them is key. And then lastly, climate change plays a major role. While residents express concern for future generations, many don't realize that risks are already here. Data from Durham Region Health Department highlights an urgent need to link climate awareness with disease prevention. Strengthening public understanding is vital to protecting community health moving forward. Next slide, please. So this assessment has been published on our website this morning and will be shared with municipal and community partners. We hope that decision makers use it to better understand the growing risks of vector-borne diseases, its link to climate change, and the need to strengthen prevention efforts. Messaging is key because prevention does not mean avoiding time in nature, which is so important to well-being. So looking ahead, health promotion in collaboration with community partners will be essential in addressing the low adoption of prevention measures and exploring innovative ways to raise awareness. Vector-borne disease spread is a serious challenge that is expected to worsen, but by enhancing education and fostering collaboration to increase prevention, Durham Region can boost preparedness and reduce infections. Next slide, please. And with that, I say thank you once again for inviting me here to present this to you today.
Thank you very much, Tara. And just on the weekend, on Sunday in CP24, there was a report identifying about the Lyme disease and ticks and how Durham Region is one of the highest areas within Ontario. So now that we're talking about education and putting that out, I think collectively as a community and at the local municipalities, be happy to help to spread this word as well too. Mayor Carter.
Thank you, Madam Chair. Tara, thank you very much for your presentation. By the way, I was introduced to a young lady at a Rotary meeting, matter of fact, in Whitby, that had Lyme disease and had paralysis and ended up in a wheelchair for over a year, and it was quite severe. And I was shocked. It was the very first time I had learned about Lyme disease. So I didn't realize it could be that serious, and I guess it's not unusual. So thank you very much for your presentation. Just out of curiosity, it sounds like it really comes down to is education is the key. Knowledge is really a key. So do you have individuals that are outreaching to our shelters, to our cooling stations, to the vulnerable population to be able to make sure they clearly understand the exposure that they may be at risk to?
I know that the vector disease program does do health communications, but I don't know how targeted it is in terms of the populations that we outlined. I'm not sure if there are others here that could speak to that today.
So part of your team, does your team do outreach?
So
Or do you have a team? I'm sorry.
Dr.
there
Kyle?
is the vector.
Oh, sorry, Tara. Dr. Kyle, I think wants to.
So Anthony and his managers are here, Director of Health Protection, so he may want to wade into this specific.
I'm just
if I may.
curious about if we've got an outreach team that could work with the community.
So right now we do at request promotional or our presentations to community partners, and we also promote through social media, but right now it's at request with community partners who looking for information on vector-borne disease transmissions.
Beautiful. Melissa's sitting right beside you. Talk to her, okay? Because she has a vulnerable population, so I appreciate that. So that's good. I think that's what it, from Tara's presentation, it sounds like knowledge is a big thing. Just out of curiosity, Tara, with the crappy May we had, does that mean that it was less likely that we had issues in May?
Through you, Madam Chair, it's a great question. It definitely, as when we talked about mosquitoes, the 14 degrees and higher, 35 degrees Celsius. So in terms of mosquito reproduction, but not so much for ticks, because ticks can remain alive up till minus 10 degrees Celsius and they become active at 4 degrees Celsius.
Darn, it was
So
2
they're
degrees
busy.
in Ottawa on Sunday, so I figured that maybe that helped the situation.
So you just have to keep your ball in the fairway.
Yeah, like that's going to happen, Madam Chair. Just out of curiosity, the exposure aspect is the highest threat, I guess. So again, as to our health education team and outreach team, we're working with municipalities to inform our works team and operations teams in regards to that's good. And our unsheltered population, we're also doing we're doing that, right? Does our outreach workers, just out of curiosity, do they inform our unsheltered population about being exposed, especially in our encampments where both Lyme disease and West Nile they would be very much exposed to it, Madam Commissioner? Oh,
Through the chair, I'm going to ask, is it Lisa, to respond to that?
I never hit, sorry, I always hit the wrong button. Can you just,
yeah,
sort of-
I'm just wondering if our outreach workers that are out there serving the unsheltered population in the encampments that are across Durham region, do they also have information in regards to West Nile and Lyme disease for that population and make sure that they're informed about it? Do you know?
so we were taking notes during the presentation. We work
Yeah.
across a whole array
Yeah.
of sort of health needs. Last presentation, I think, from the health department that really resonated was the sun safety component. But again, a lot of times we're doing basic, like keeping people hydrated, staying away from heat exhaustion. Ticks this year are really high. So again, the team as well as individuals who are living outdoors are all, the team is definitely talking about ticks because they have to monitor while they're going through
I
the
was-
bush and in places.
Yeah, I was going to say it
as-
exposed them to it too, right, at the same time.
So it is a conversation, and even in backyards,
Yeah.
we've been having conversations about like our own backyard at 1635 and other properties.
Wow. Okay, great. Thank you very much. I greatly appreciate that. And Tara, you made a reference to black tea. You had another word for it, but you're seeing this type of tick that I guess is kind of dangerous, or
It's the black-legged tick, and it is
black-legged?
black-legged tick. So we have many types of ticks, in our environment, but that
Yeah.
is the one that carries Lyme disease, as well as some of these other emerging diseases of public health significance.
Okay, and are you seeing an increase in that? Of this
Yes.
particular type? And is there
Yes.
a place, is these black-legged ticks, are they all across North America, or are they new to this area?
They have been expanding over years. I think they're in the United States and moving north, starting in the east and then moving west, and very rapidly, as the slides showed in the presentation.
Yeah.
And they are continuing to move north.
I just have
And-
to ask
and
this because
west.
I don't know. The ticks fly? Or they crawl, or do they walk?
No,
No, they don't fly?
No.
They walk?
no,
I just say, because they came from the States, they go, man, that's one heck of a walk, So I just say, but they don't fly?
No, it's an important question, and we didn't explain it in the presentation, but they exist in brushy, grassy areas. So when you brush past, yourself or your pet picks them up,
Yeah,
and when they bite, you can't feel it.
yeah,
So a person might not know they even have a tick bite unless they actively look for it.
wow,
And so it's those pieces that we really want to convey, because just by checking and finding one, because they can feed and leave,
yeah,
and a person may not even know it.
Yeah.
So it's those, really proactive measures that are essential, and they're easy.
yeah,
And that's the other part, that we want to stress, is that it doesn't mean you don't need to spend time in nature or enjoy the things that you love,
yeah,
but just add a few extra steps into the process,
Yeah.
and to check for ticks.
Agricultural workers that work outside, the unsheltered, that's heavy exposure. And I think it's one of the reasons why, Madam Chair, I do not support the encampment aspects, because we are exposing people to West Nile and to these tick diseases and everything else. It's horrific. So thank you very much. Appreciate it. Thank you, Tara. Great job. And
Thank you.
I wish you the best of the day.
Thank you very much. We have a number of speakers. So I have Councillor Anderson, Councillor Brenner, Councillor Dyes, Councillor Kerr, and Councillor McDougall. So I'm going to turn to Councillor Anderson first.
Thank you, Tara, for the presentation. When you talk about tick-prone areas, what exactly are you referring to? I usually or folks associate tick with livestock. Is that correct?
So tick-prone areas would be any area where you would be exposed to leaf litter, brushy grass, long grass, bushes, edges of forest, in forests. Typically it is possible to be exposed on mowed lawn, but it's far less likely. So they tend to live and exist. They really love leaf litter, particularly wet leaf litter, so precipitation in the spring. People digging in their gardens or going for walks. These would be typical exposure areas.
So if you come across a tick, what's the best method of getting rid of it or whatever?
You remove it.
Huh?
You remove it.
You remove it. Okay.
Sorry, Tara.
Yeah.
And it's my
No, I appreciate.
tweezer. Okay. It's my
This-
understanding that there's no cure for Lyme disease, correct?
So again, this is where the prevention part is key, and I'm sure there's others in this room who would answer this question better than I, but prevention is key. And so if you find a tick bite and it hasn't been attached for over 24 hours, the risk is low. But if it's been attached longer, then you do need to, see your healthcare provider and seek treatment. But the earlier, the better. And this is, again, why we keep stressing, look for ticks, ideally find them before they even bite.
Okay.
And then in terms of removal, there are many instructions, and there's also a lot of misinformation. So that's something that's really important to clarify as well about the proper process to do that. And we have that information on our website.
Okay. So you're saying immediate treatment is the key then?
Yeah, the sooner the better. And that's why we talked about understanding what the risks are, understanding signs and symptoms. All of that education is really important.
Okay. Thank you very much. Thank you.
Thank you, Councillor Brenner.
Thank you, Madam Chair. Thank you for excellent presentation. I know that when we talk about ticks and Lyme disease, and talked about it last year around the same time, one of the questions that I do have, and it has more to do with your work with the area municipalities and the various public works department. The scenario that I'm going to provide is real, it's factual. Many municipalities, including our own in the region, we go to great lengths at times that we want to preserve nature. We do, especially when we're top of bank or abutting forested areas. What I notice more and more, and I see it when I'm walking my own dogs, is that the buffer zone between where the grass cutting crews are cutting back appear to be narrower than they should be. And one of the concerns I have is that ticks are transmitted in leafy areas. We know they don't fly, but they do drop off when you're walking by in close proximity. And they can make their way from grass to a leaf on a tree and where there's overhangs and become a risk factor. What steps can we take to revisit the question of the buffering between long grasses and pedestrian walkways, our trailways, even when we're going through protected areas?
Thank you for the question. And we do, in our advice, ask people, recommend to stay on the mowed paths or the designated paths. In terms of the buffer areas, I couldn't speak to that. I'm not sure if someone else in the room can, or we could come back to you with an answer to that question.
Perhaps come back to me, if there is no one that can provide it. I know that I have a great rapport with our Commissioner of Works. They do amazing work. Our contractors do fantastic works. But it's unclear as to how far back is acceptable, and maybe we need to revisit it. And I say that because if, in fact, statistics are showing that we are on the rise in Durham region in particular, I think it needs to be a red flag because, as you point out rightfully, prevention is the way to go, and education is really important, but we also want to enjoy the outdoors at the same time.
Indeed. Thank you.
Thank you.
Thank you. Councillor Dice.
Thank you, Madam Chair. This is something that in my generation we never had to really worry about. And I know that, for instance, I know people who have actually picked up ticks in their backyard. And it seems that wherever we go, we're still at risk. The issue seemed to be a while ago, though, that our GPs weren't really able to or didn't recognize the symptoms because it was such a rare occurrence. Is that changing in the medical industry? Are we now able to go to the GP and get that diagnosis?
Dr. Kyle, do you want to answer that one?
So the short answer is I don't know. I think that both Lyme disease and West Nile virus disease is less unfamiliar to primary care. And as you heard from Tara, depending on when the exposure occurred, whether there are signs and symptoms, and if you will, the time period between exposure and onset of signs and symptoms, I think there's enough in the medical literature to provide guidance to primary care if somebody showed up with telltale symptoms and signs. So my hope would be that primary care can handle the bulk of the cases, but have we surveyed them to find out their capacity in terms of treatment? No, we haven't done that. So I'm turning to Dr. McTavish, who may want to add to what I've said.
Thanks, Dr. Kyle. So I would say that in places where ticks have been well established before, like sort of the Kingston area, so that's where I trained, it's definitely well known. Everyone is like when people come in, you have a tick, the docs know what to do, there's good treatment, good prophylaxis, and then that is spread. As the ticks continue to spread, sort of the education goes with it. So we spend a lot of time letting our local primary care providers know about what to look for, how to access treatment. The province has done a really good job of putting out information to physicians and nurse practitioners, and even, I think it was last year or the year before, pharmacists can now provide medication. So if someone goes into their pharmacist and says, I have a tick, I don't have a primary care doctor, the pharmacist can give the prophylaxis, which is just a one dose, 200 milligrams of doxycycline. So it's an easy treatment. There's lots of good information out there. So there is lots of information. Could we do a better job? Absolutely. But I think at least twice or three times a year, we have great information. I present to our new family medicine residents on Monday. A big part of the presentation is actually about being aware of Lyme and black-legged tick diseases. So it's out there. Yep, absolutely. It's a good question. Thank you.
Further.
Well, I appreciate that because the prophylaxis was another question as well. So we can then say to people who have concerns that they can go to the drugstore, the pharmacist, or they can go to the doctor and be treated. So that's good to know. Thank you.
Thank you. Councillor Kerr.
Thank you, Chair. And through you to Tara. So 3 areas. One, are we basically saying that as the average temperature increases throughout the spring, summer, and fall season, that if I can call it, the bug season lengthens as well?
Yes, that's correct.
Okay. With respect to Mayor Carter's question about it's been a long walk for the black-legged ticks to go from the States up to Canada, would they hitchhike via birds and other, animals to help them make the trek, and then they basically jump off when they get here and start propagating? I mean, it is an awfully long walk. So how would they get here?
It is a long walk, but insects don't have much else going on. So sorry.
You got to get them something to do. Besides bite us.
So they're persistent, but added to that, you're absolutely correct. They can travel on birds, and which is why whenever we show the maps or of the high risk areas, we also, make a point to say that just because there are these high risk areas, you can be exposed in other areas that aren't considered high risk because of the bird travel. So a bird could bring a tick and then they start to, spread from there.
Well, birds doing
The
what
the
they
one
do,
thing,
that flutter thing, right? They may shake off ticks once they get here.
and well, and when ticks are finished feeding, they drop off. They'll attach, they feed, and then they drop off. So
I don't know. I've just seen the wild turkeys up at my cottage, and there's this little sandy area there. They like to take a sand bath in the middle of the summer. And then when they flap, I can't believe how much dust flies off of those turkeys. So anyway, I digress. The last area it's a personal question, and I'm wondering how whether this has affected black fly population. I don't think we have as many black flies, if at all, in and around this area. But I've noticed the last 2 years at my cottage, black flies never really bothered me that much. I get the odd bite and it's a little red welt. The last 2 years, when I get a bite or two, a significant area around there gets red and swells up. And last weekend, I had my daughter bought me one of these hats with a mesh on it, and I made the mistake of doing it up too tight, and then it rode up. And I was in my Ride-'em lawnmower. I had 20 black fly bites across here. My whole neck swelled up, and it was really itchy. So it's really uncomfortable. I'm wondering, has been a change in the, I forget what the word is. Have there any change in the symptoms of black fly bites? Has this been exacerbated by climate change? Are there changes in what black flies carry? I know they don't develop mouths for the first 2 weeks of their existence, which is why they're so voracious. When the mouths come in, they just completely go for you like a heat source. So is there anything that's affecting the black fly population as well as mosquitoes and ticks? Long-winded question, sorry, but.
no, thank you for the question. And so in our review of vector-borne diseases, black flies didn't come up. That said, I'm happy to take a look to see if there's any information about it and share that with you.
Thank you. I would appreciate it. I mean, I'm taking measures. I forgot to put
Thank you, Councillor
gloves
Kerr.
on. Anyway, I know, entertaining maybe, but I appreciate it.
Thank you. Councillor McDougall. Try again.
Oh, there you go. Sorry. Thank you. I had my mic off. Thank you for the presentation. I can't help but think, as a northern resident, often when we show the map of Durham region, it ends at Highway 7. But realistically, when we look at Durham as a whole, it's almost predominantly probably 75% uninhabited, let's say, and it's rural. And so, when I look at the new urban park that's been created in Uxbridge, or rural areas around Scugog and Brock, Clarington, and even down Whitby, Oshawa North, etc., I can't help but think there's a large area. We keep concentrating on employment and in terms of, let's say farm workers, etc. But we have a large amount of residents that we're trying to drive regularly out into, Durham Forest to say, go mountain biking or go hiking or go explore all these areas. Do we have, and I think someone kind of alluded to this, but I can't say for myself that I've seen an active educational outreach program to say, it's great that you're visiting these outdoor areas, but what protections are you taking? Through you, Madam Chair.
Thank you. Through you, Chair. Thank you for the question. And I think that's exactly where we're pointing to in terms of the next steps of this report is, what else can we be doing? So we want to initiate those discussions. What else can we be doing to reach people in a more targeted fashion that speaks to their specific context? I know we don't have much time, but I am one of those people. I live in a rural area with kids. We are out and about. I live on a rural property with everything, and we encounter ticks a lot. We have a very strict protocol in the house, and it works after lessons learned. But so all that to say that there really is excellent prevention methods and not expensive, which is always wonderful. But as we mentioned, this report really points to the fact that we need to have further conversations about how we need to do that. And as I mentioned in the presentation, it's not just Durham, it's across Canada. There's federal reports saying we really need innovation around communication, particularly around Lyme disease.
And thank you for that. And then I know for myself, it's often brought into the house via our dogs, Labradoodles, They might not shed, but they sure drop ticks off. And my understanding that a lot of these ticks have been spread through deer and other natural animals that are constantly in the brush. So I'm not sure, but I mean, certainly that's not something we can do in terms of the movement of ticks. It's going to occur naturally, much like Phragmites in the environment as well. In terms of protection, it's been mentioned that spray in terms of like bug spray, but certainly there's some fear of the population, like don't use a bug spray with DEET in it, or people don't know what to do because they're afraid, you know, if I use the sunscreen, is that going to damage me as much as the sun itself? There's a concern in the population in terms of, you know, what is other than for ticks, let's say, we know that having long clothes, long socks, etc. would work, but in terms of bug sprays, what do they need to apply and when do they need to apply it?
Thank you for that question. And you're absolutely right. In the presentation, we acknowledge that the majority of people surveyed with Lyme disease and West Nile virus don't use or didn't use bug spray. And so it points to some need for some health promotion education around that as well as providing options, because there are DEET-free options, effective ones. So absolutely, it points to the need to promote those and perhaps do some education around the safety of those items.
And then my last question is you mentioned that they can bite and fall off and you might not get the bullseye rash or whatever around the bite. I think, I'm not sure for what you mentioned, West Nile, is there a blood test for West Nile that will confirm a positive result? And is there the same test for Lyme disease that would confirm or deny a positive result? Through you, Madam Chair.
Dr. Kyle.
Thank you.
So in terms of a blood test for Lyme disease, I'll turn it over to Dr. McTavish. She's our resident expert.
Thanks, Dr. Kyle. That's a great question. There's great testing, and our colleagues at Public Health Ontario are world-class experts in the type of testing that are done for all sorts of different diseases, but especially the viral diseases. Every few years they update it, they figure out what the new and best tests are. They tell us, we sort of filter that down to family doctors and infectious disease doctors in the community. But one of the neat things about those other black-legged ticks diseases that Tara mentioned, the new ones that became diseases of public health significance in 2023, is that they always have to have the lab testing to go along with that. You can't say, let's make this a diagnosed or a reportable disease, but without having the lab testing. So that piece usually comes first. So there are blood tests for all of these diseases, which is great. Usually that's done after sort of different symptoms, what's happening, why do you still have headaches, why do you still have weakness? And usually by that point, sometimes it's the infectious disease doctors that are involved, because these are still very rarely diagnosed in Ontario. But absolutely, there are tests out there, they're blood tests, and they're used very appropriately and created and distributed by Public Health Ontario. It's a great question. Thanks.
Yeah, very good. Thank you all. Thank you.
Thank you very much, Councillor McDougall. That's the last on our speakers list. I do have just a question just around education, because it was stated it's not just about being out within our open areas, but it's also about being in our backyards. West Nile and Lyme disease. So West Nile is where there's breeding sites for mosquitoes. One of the areas is a pool, and some of the community members, and I know this comes under property standards, but are we having a working relationship with our bylaw departments, with our local municipalities as well? Dr. Kyle?
Anthony, Director of Health Protection, will take that. Thanks.
Great. Thank you, Madam Chair, for the question. Yes, we have a great working relationship with all the municipalities and their bylaw departments. When a complaint is made to the region or to the municipality, the municipality will take the first kick at the can to remediate the situation and speak to the homeowner. And then if there is continued non-compliance, then it's passed over to public health, and then we'll follow up and investigate, determine if there's a mosquito larvae found, and potentially issue an order and go from there until the solution is remediated. And we will, if we find larvae, we immediately treat it to remove the hazard.
Okay. And then the next question is that, dog owners, and many of the dog owners do utilize our dog parks and even with our own parks. What is the communication also not through to our parks, but to our CLOCA and to our conservation authorities, just about educating? Because I know that right now it was commented about the May time period with the amount of rain, there's a lot of standing water, but also with our dog parks, with the freedom of the dogs just to go. I know that with my own children and my own dogs, we check our dogs frequently, but it is a case of where the dogs do bring in the little critters into wherever it might be. So are we working with the conservation authorities on even educating there?
Thank you, Madam Chair. If it's possible, I'd like to pass it to my manager who works with the agencies, Brenda Kwan.
Thank you for the question. So we have, last year, we worked with the municipalities to distribute all, and the conservation areas, signs with prevention messaging with regards to ticks. So they were able to order all the signs that they needed to put at the entrances of all the conservation areas. We have also produced some videos that are on our YouTube channel now. And so through our websites, we're able to point people with a lot of great information. And if anybody requests presentations, we are happy to direct our presentations to them.
Okay, and I did kind of make the joke towards Mayor Carter about keeping it in the fairway, but I actually have a tool that's attached to my golf bag, and it is a tick remover as well, because when your ball doesn't stay in the fairway, Mayor Carter, I might get you this tool. Thank you very much, Tara, for your presentation. Next,
you.
we're moving on to Ashley Smith, Supervisor of Homeless System Management, and Melody, I'm going to get this wrong, Disineka, the Data Analyst Coordinator for Everyone Counts, and please correct me with your last name, the point-in-time count of homelessness in Durham Region. Ashley and Melanie, thank you very much.
Good morning. Thanks for having us. My name is Ashley, and this is my colleague Melanie, and today we're going to speak about the point-in-time count. So the point-in-time count, also known as the PIC count, is a coordinated data collection initiative aimed at capturing the number of individuals experiencing homelessness within a specific region over a 24-hour period. In Durham Region, the PIC count was conducted on November 18th, 2024, and consisted of two key components: the enumeration, which involves identifying individuals experiencing homelessness, and the survey collection, which gathers more detailed data on their experiences. The enumeration took place within a carefully planned 24-hour period, providing a snapshot of homelessness at that specific point in time. This was to ensure that we had an accurate count of individuals in need. Surveys were also distributed to individuals experiencing homelessness, with the survey collection period remaining open until November 22nd. This extended period allowed for the collection of valuable information on their personal experiences, needs, and characteristics, offering a deeper understanding of the issue of homelessness throughout the region of Durham. The enumeration component provides a comprehensive count of homelessness across Durham Region as of November 18th, 2024. This effort focused on identifying key locations where individuals experiencing homelessness are typically found, including shelters, transitional housing, and unsheltered areas such as parks, parking lots, and encampments. Additionally, community spaces like hospitals, libraries, food banks, and meal programs were also included in the enumeration. For individuals who are counted and provide their consent, a standardized survey is then administered. This survey collects valuable data about their characteristics, experiences, and specific challenges, offering crucial insights into the realities of homelessness within the region of Durham. In preparation for the 2024 PIC count, we took a comprehensive and collaborative approach to ensure thorough planning and alignment. We held bi-weekly meetings with the PIC committee, which included community partners, outreach teams, and the GAP committee. These meetings kept us all aligned and allowed for regular updates and shared insights. Additionally, we worked closely with outreach teams and bylaw officers to identify key hotspots and design targeted routes for the enumeration. By adopting this targeted approach, we were able to leverage expertise of local agencies and tailor our efforts to the unique needs of each community throughout the region. This approach enabled us to adjust our strategies more effectively and reach unsheltered individuals. So to recruit volunteers, we reached out to all funded agencies, violence against women organizations, local colleges and universities, as well as our own internal staff. On the day of the enumeration, we formed teams that included leads from both regional and external outreach programs. This collaboration combined local knowledge and expertise, ensuring the safety of our volunteers and creating an environment where individuals experiencing homelessness felt more secure and as a result of the established relationships our outreach teams had already built with them. So the survey period for the PIT count was open from 4 p.m. on November 18th, 2024 to 4 p.m. on November 22nd, 2024. During this time, we targeted a variety of locations to ensure we captured a comprehensive snapshot of homelessness throughout the region. These locations included shelters, libraries, daytime programming, hubs, and motels. And by targeting these diverse spaces, we were able to capture a wide range of experiences and ensure that a broad spectrum of voices informed our understanding of how individuals experience homelessness across the region. I'm now going to turn the microphone over to my colleague Melanie, who will speak about some of our key findings.
Thank you, Ashley. So I will jump into the significant findings that we got from the PIT count. So an analysis of the 2024 PIT count data revealed the following significant findings. At least 1,345 individuals experienced homelessness on November 18th to November 19th in Durham Region, which speaks to the enumeration portion of the count. Of the 1,345 individuals, 540 individuals consented to participate in the survey and provide an understanding of their experiences with homelessness in Durham Region. So we identified that there was a 66% increase in the numbers as compared to the by name list for November 2024, which we documented had 811 individuals. Finally, we observed that there was a significant increase by 134% of the number of individuals documented experiencing homelessness overall as compared to our numbers from the 2021 PIT count. So from our sample, we did see that the highest number of survey responses were from Oshawa, Whitby, and Ajax, with Oshawa seeing the largest rise. Possible reasons for a higher count could be due to an increase in the number of individuals living in these areas, as well as the availability of homeless and social services to support the complexity of these individuals' needs. Now, when comparing to 2021 data, a significant growth of homelessness was observed across most regions in Durham Region. So that included Whitby, Pickering, Uxbridge, and Oshawa. So the analysis of the overnight locations demonstrated that 45% of the participants were staying in sheltered locations, which included emergency shelters or regionally funded hotels and motels. 33% of the survey participants were staying at unsheltered locations or were in unsure locations. So unsheltered locations included unsheltered public spaces such as a street, a park, a bus shelter, forest, or abandoned building. Encampments, so a group of tents, makeshift shelters, or other long-term settlements, and vehicles, so a car, van, an RV, a truck, or a boat. 15% of the individuals were noted either staying at someone else's place or at a self-funded hotel or motel during the night of the count, and 3% of participants were staying in transitional housing facilities. So we know that homelessness can be experienced by anyone regardless of age or gender, and the findings revealed that the majority of survey respondents were adults, and that accounted for 343 responses, followed by older adults who contributed to 127 responses. In comparison to 2021 data, there was a significant increase in adults and older adults, with a 95% increase and a 38% increase respectively. So data on gender revealed that 59% of survey participants identified as male, followed by 40%, which identified as female, and 1% as another gender identity, which included genders such as non-binary and trans. The proportions of this data were also very consistent with the data from the 2021 PIT count as well. So if we take a look at this chart, it shows the racial or ethnic distribution of individuals experiencing homelessness during the PIC count, race data revealed that white individuals made up 67% of the population. Black individuals represented a significant portion at 27%, while smaller percentages are seen in other ethnic groups, with Asian at 3%, Arab at 1%, and Latin American at 1%. So this distribution highlights disparities in homelessness across different racial and ethnic groups. Now, out of the 540 individuals, 65 individuals identified as having Indigenous identity, which made up 12% of the overall sample. So specifically having Indigenous ancestry, that was 2%, so we saw 12 responses. Being First Nations, that was 5%, so we saw 28 responses. Being Inuit, that was 1%, so we saw 4 responses. And being Métis, which is 4%, and we saw 21 responses. So based on the most up-to-date consensus data, there was a significant overrepresentation of Black individuals and Indigenous peoples in the PIC count, considering the overall population for both categories in Durham Region are 9.5% and 2% respectively. So when we look at the experiences of homelessness, about 57% of individuals identified as chronically homeless, experiencing 180 days or more of homelessness in the last 12 months. This indicates a significant need for permanent housing and long-term care strategies to break the cycle of repeated homelessness. About 83% of individuals experiencing homelessness identified as living alone, which illuminates the demand for housing models that prioritize single adult units and individualized wraparound supports. About 7% of individuals identified as being homeless with children and dependents. So there were a total of 93 children identified as dependents, and the youngest age recorded was a year old. So although a smaller proportion of the sample, this group does face unique vulnerabilities that require coordinated family-centered responses, pointing to the urgent need for early intervention and prevention services that address child and family well-being. So we look at the circumstantial causes for homelessness. Almost half of the people we heard from became homeless between the ages of 25 and 49, and another 18% between 50 and 64. So this demonstrates that it's not just young people, but many are losing stable housing well into adulthood, often during key working years or as they start to face health and financial issues, thus pointing to how vulnerable people can be even in the later stages of life. About 15% of surveyed responses had been in the foster care system at some point, which is relatively large considering the sample size. And this demonstrates that youth aging out of care don't have the supports that they need to stay housed and stable and are falling through the cracks or at risk for it. Now, we looked at health. Over half of the individuals reported mental health concerns, and about the same said they deal with substance use challenges. So you add in physical limitations, as you can see on the chart there, and it becomes clear that many are dealing with complex overlapping health needs. So, sorry, next slide. Okay. So when we look at the key factors that contributed to recent homelessness, that was driven primarily by the lack of sufficient income for housing, accounting for 29% of cases. Issues with a spouse or partner followed closely behind, contributing to 15% of cases, while landlord-related problems made up 14%. So relocation factors were also significant, contributing to 11% of homelessness cases. Additionally, unfit or unsafe housing conditions contributed to 9.6%, highlighting the importance of both economic and housing quality issues in driving homelessness. So when we looked at the sources of income, primary sources were documented amongst survey participants as welfare or social assistance, which was 55%, disability benefits at 23%, and ODSP at 11%. Also, 1 in 3 people said they lost their housing because of an eviction. This number is substantial and shows how many are just one crisis or one missed rent payment away from homelessness. It also speaks to the need for stronger protections and support before people get to that point. Lastly, when analyzing how people have been without how long people have been without housing, about 36% had only recently lost housing in the past year, which demonstrates them being quite new to homelessness. However, another third had been without stable housing for 1 to 5 years, demonstrating that there are both short-term crises and long-term crises that are ongoing with regards to homelessness. So as next steps, we are using this data to continuously contextualize and interpret the findings. Specifically, we will place the results within the broader context and compare results against national benchmarks to assess how Durham Region data aligns with broader trends. We will also continue to identify existing gaps and prioritize interventions. We will use the data to pinpoint where the biggest gaps in housing, health, and support services are so that we can target interventions for where they're most needed and in the most efficient way. We will continue to strengthen prevention strategies. Through utilizing this data, we know that a large share of people became homeless due to eviction or during key life transitions. This knowledge will help us shape more effective prevention programs, especially around housing security and income support. And lastly, as this presentation does share key findings from the 2024 PIC count, a full report including more detailed data and analysis will be released this summer. We know there's a strong need for up-to-date local information to help with planning, decision-making, and support services as homelessness does continue to grow. So these findings are meant to be helpful to community partners for them to stay informed, and we hope that this is useful as we work together to respond to this important issue.
Thank you very much for the information today. Mayor Carter.
Thank you, Madam Chair. Sorry to be a pain today, but a lot of reports have a lot of information that's really important. First of all, thank you for your presentation to both of you. I have a series of questions I'm wondering if you might be able to help me understand. On your teams that participated, how many individuals were part of those teams?
So we actually adjusted the team sizes based on the feedback that we had from our outreach teams as well as our bylaw teams. So for example, if we had larger reports of a homeless population in certain areas, then we had those teams as larger, just because we knew we were going to have more surveys to complete, et cetera.
Okay.
So we did adjust them, but they did average, the minimum amount was 2 people
Yeah.
on a team, and we had some that went up to about 7.
Okay, great. This is really puzzling to me. So why do you do the pet count in November? That's low season. High season starts about the 3rd week of April and goes right through till October. That's where the largest population and where the largest group of individuals that are unsheltered appear in all of our cities. So I'm curious about why November when it's at the lowest point instead of the highest point.
So, and that's an interesting question. So we are mandated by the federal government to complete the PIC count between October 1st and November 30th throughout all communities across Canada. So that is something that we have to do. So those dates are determined by the
federal government, did you say?
Yes.
Okay, but does that mean that we're limited? Because this information is for our region to be able to provide the services that are necessary for this population. So does that mean that we're limited in regards to not doing a PIC count in the high season?
So we can choose between doing it from October 1st until November 30th. And so we have talked internally about looking at moving those dates up. When we had spoken to our PIC committee, which, as we had spoken about, was made up from our external agencies, our community partners, et cetera, it was seen that doing it in November would be a good time to do it because of it being around, so with October, with the weather being so, what was the word here? With the weather being...
favorable?
No, it was more that it was hard to pick a good time to do it around Thanksgiving because a lot of people will go home. That was the input that we had from our committee. And so we did choose November 19th, or 18th, sorry, till the 19th.
I think it's just my opinion.
Yeah.
You're professionals and I would encourage you to advocate in regards to high season. I think that would give us better information in regards to the community. So it's just my suggestion, but you take it under consideration, please, because we know what our accounts are. And I can tell you that in November, December, January, February, and March, those numbers are much lower in regards to all categories. But it would be better maybe in that season. But just take it under consideration.
thank you.
Yeah,
Appreciate that
I'd
feedback.
appreciate that. The bi-weekly meetings,
Mayor Carter, just hold on. Councillor Kerr, I'll get you to make a response afterwards to Mayor Carter, because you are next. Go ahead, Mayor. Mayor Carter.
I don't even know who's
Councillor
responding to what.
Councillor Kerr was going to give a response, but
In regards to the pit count?
yeah. So
Okay.
Mayor Carter, please go ahead.
Okay, thank you. I just didn't know where that was going. The pit count bi-weekly meetings, you utilize community partners, outreach, GAP group. Did you talk to the cities and our safety and facilities departments at all 8 municipalities to get their data?
We did meet with the local bylaws, and we did reach out to the cities as well, just to find out if they had hotspots, any information they could give us on where we should target our enumeration routes, and
Okay.
utilize their feedback to determine those routes.
Did you include the 35,000 data points that we provided last year in regards to this count?
Yes, we did.
Okay, that's good. Thank you very much. Appreciate that. I asked you about the teams, so that's good. The pit count, at least 1,345 individuals experienced homelessness November 18th to November 19th, 2024. Where was their place of origin? What breakdown did you get into the place of origin of those individuals?
Sure.
And what percentages?
Yep. So it was the highest survey responses were found in Oshawa, Ajax, and Whitby.
Okay, so that's where the place of origin, so that's where they were living before, and that's where they're seeking the services. So they're not from outside the area, they're not transient, they actually lived in Oshawa, Ajax, or Clarington, or Pickering, and that's where they were seeking those services. Is that what you're saying?
So through the chair, I'll defer to Lisa.
That information is always limited with this population because they are transient by nature. So we do collect the best data in the self-report that they provide. But again, we move people around to access shelter or transitional housing or supports. So the information we gather is the best that they're willing to tell us at the moment.
I get that, but they're sharing a lot of information that you're including in these reports, and you would think that place of origin, where they were born, where they grew up, where their home was, where their family is, would be an easy question. You talk about, if they're male, they're female, what's sexual orientation, what gender or what religion they are. I mean, there's a lot of information that they're making available to you. So I guess the obvious question would be, why wouldn't all that information, why would it be that hard, I guess?
It's one of those questions that, again, people are concerned that their service delivery would be terminated or ended or access would cease if they provide information that is that could be within policy limiting. And we have seen those systemic barriers exist recently in our programs.
So you could point to some organization that may be faith-based that require faith-based.
No, really, we had an old, and I think Melissa in her presentation referred to it. We had a process in Durham where if you didn't state that you had been in Durham for more than 90 days, that we wouldn't give you a shelter bed for a very long time here. That ceased in 2023 when we really understood what was happening in practice across organizations. Because again, somebody who is creating or is outdoors and people are calling to say, why are they outdoors? A rule that, well, they can't prove they were outdoors in Durham for 90 days didn't make sense. So that rule doesn't exist, but honestly, those who've been using shelter for 1 to 5 years or who've been unsheltered in Durham, they're still sitting with what existed in that. Also, we had time-limited sheltering, which meant that you started to stabilize and decompress, and we sent you back outdoors for a while, and then would take you back again. And so people are really nervous about
Okay.
that. So
Thank-
hopefully over time, we'll
Yeah.
get better
Yeah.
data and deeper data.
And as you know, more data, more
Yep.
granular we can get, the better it is, because we're trying to figure this out, and the more data we get, it's the better it is. So thank you,
Definitely.
Lisa.
Thank
I
you.
really appreciate that. I'm going to break down by municipalities. The highest survey responses were in Oshawa, Whitby, and Ajax, 52%. I'm just wondering, was people in Oshawa, they were just a lot more open to participating and not so much in Ajax, or?
So I think it also could be due to the increased number of individuals like just living in the areas, and then the availability of like homelessness social support services in those areas. So you're more likely to see them.
So that brings me to a question: is through your count, were you able to determine why Oshawa would have the highest number of individuals that you've been able to identify versus, let's say, Ajax or Whitby?
So not specifically from the data process itself,
Yeah.
because we didn't ask that through the survey.
So you didn't ask them why they were in Oshawa or Ajax or Whitby. Do you think that might be good information to be able to gather through this population so that you can understand? Because I've tried to figure it out, and I know that in Ajax, they have the exact same amount of services that we do. But
Right.
our population is always 2 or 3 or 4 times the population can't figure it out. So we're trying to understand that. So
Right.
would that be beneficial?
It's a great question. We also were working according to the mandated survey questions that were provided. And so we,
The mandated questions?
by the federal
Who's-
government.
So the federal government is telling you what questions to ask?
They are, and so we have opportunity to provide feedback. And so this is great feedback that you have
I-
brought up that we will
It'd be
actually
great
relate
if
to
you
them.
could advocate in regards to that. Again, as I'm going to go to age and gender, most of them are adults. I see the age group is 25 to 49. And I think I don't think for any of us that's a surprise. What we're still trying to figure out is why is 60% male? Do you have any idea why 60% of the individuals that you're counting are male?
We can speak to some of the pieces that our data is showing us. So for example, when you look at the number of individuals who are in receipt of social assistance and the low social assistance rates that we know that we have across Ontario, that would impact single males higher. They're not receiving child tax. There isn't those same benefits that they have access to. So it can impact one's ability to access safe, affordable housing as well. So there's those pieces, but we can look into that more and get you a better
Great.
answer if you'd like.
Yeah, I'm just fascinated by the data. And then I'm going to move on to when you did specific racial identities. This goes, Lisa, to the granular of this and other issues. I'm wondering why Latin America, Asian, Arab, why they're so low in regards to being represented in this population. Do you have any concept of that at all?
It's not a particular question that we asked. It was just part of the findings. So
Right.
we wouldn't be able to answer that.
Right. But aren't you
with-
curious?
I am curious, and I think with further research, perhaps we could take a look at the literature to see perhaps why there's a reason.
It'd be really
these numbers
interesting
are
to be
low.
able to figure out, is there something different happening in their family units or what else? Again, we're looking at trying to answer these questions and to find that magic key, which I think all of us are looking for. We can't find it. So the pick count gives us an opportunity to do that. When I look at your 57% individuals identified as chronically homeless, which means 180 days, this is where it gets problematic because many of our chronic homelessness for 180 days start by the middle of April and end by the middle of November. That's 180 days. The rest of the time, they're somewhere else. And so that's why I go back to, I think it would be beneficial to be able to do the count at high season instead of low season. That may help. That being said, was there a reason that was common in regards to the 180 days?
Sorry, I just wanted to speak first to the 180 days. So although they might not be outdoors experiencing homelessness,
Yeah.
when we look at our by name list and we're looking at chronic homelessness throughout the region of Durham, we still do consider somebody to be homeless when they are couch surfing or precariously housed.
Thank
So
you for
those,
that.
that
Okay.
is consistent there.
Okay.
With regards to the reasons that people are experiencing homelessness, I believe one of our slides did speak to it, with low income, evictions.
I'm going to get to that because you know, primary reasons is primary source of income. But a large majority of those that are unsheltered depend upon OW.
Yes.
So this is an economic issue that we're talking about, or ODSP, which is another issue, right? So I think that's interesting to be able to see that those numbers are as high, but I don't think that that's a surprise. I don't think it's shocking, right?
No, and it does go in line with our continual advocacy for higher social assistance rates. And I can say that we are also working to help people to gain further social assistance and move on to ODSP and getting them proper care. So we are doing those pieces as well.
I know that you've been dictated or you've been asked through the federal government, asked specific questions under this count. But it would be interesting if you could, you just spoke about the couch surfing and that, from the 180 days onward, about where else do you reside and have that included. I think that data would also help us too, so that we have a better understanding of who's living rough, who's not, and that comes down to it. Again, take it under consideration. I know that I didn't realize that it was legislatively dictated, which is problematic because we're trying to figure out local solutions to the local problems. And substance abuse and mental health seems to be front and center. I know that in Oshawa, our data shows that 96% have high acuity, which means that they have both mental health and addiction issues, and we're seeing it through the calls that we're dealing with. The severity of illness out there is just off the charts, so it's unbelievable. You already answered in regards to the economics of it. You made a statement that said they're one rent check away from being homeless. I understand what you're trying to say, but have you ever dealt with the landlord-tenant board? Because it takes months and months, and in some circumstances, years for individuals to appear in front of a landlord-tenant board. And in many circumstances, they're now 12, 14, 16 months behind that they've never paid rent. So I found that was an interesting statement, that's all. So anyway, so the last thing is this benchmark. So again, is this legislatively, or is this, because I would think that we would want to compare size of our region with other regions that are doing these pick counts and seeing where the similarities are and seeing, does it differ in York? And why does it differ in York or Peel? And so what are they doing different that we are not doing, and what can we do? But the comparison, is that legislatively dictated that you're only to do Durham region and that's it? Or you can't compare with other regions? Do you guys share information?
Sorry, yes.
Oh, you do? Okay, good.
You can look on, so I went to a training with other regions as well, so that
Yeah.
it is standardized. It's presented in the same way across Canada.
Okay.
The account, which is why they do
They
have it
put
through
it
the
in the
same
legislative-
timeframes
oh,
as well,
okay.
right?
Yeah.
However, when you do look at the growth in homelessness and what we're seeing in Durham region, it is on par with other areas. So when you look at, for example, Niagara, Ottawa, although their numbers look larger, when you compare them to their 2021 pick count, that growth is very similar. So we are looking at those pieces, and there will be more information in our report as well.
And I think that the racial makeup is going to be different. I noticed that when I was in Ottawa this weekend, there's a large population of First Nations that are suffering with severe addiction and mental health there. But it would be interesting to see what York and Peel say in
Yes.
regards to that. So, hey guys, thank you very much. I really appreciate it, and keep up the good work. But please take that under consideration. See if we could do a count at high season, please. I think it would be very helpful. And reach out to our city. I know that we've got data that could be very helpful throughout the year. So keep those conversations going. Madam Chair, thank you very much.
Thank you. Is there any members from the committee who want to speak to this or ask questions? If not, Councillor Kerr.
Thank you, Chair. Lots of questions, lots to say, but first I'd like to perhaps provide some helpful information for Mayor Carter's line of questioning about the times of year. As a preface to this, I was a professor for 30 years, and one of the courses I taught was contemporary Canadian social issues. And every semester, every iteration of the course, I always included homelessness because of its significance. So I'm not without some background information in this area. I would suggest that the reason why the count was taken in November is because that's when you're going to get the truest number of local people who are homeless. And the reason why I say that, in summer, I'll take the squeegee kids example from several years ago. When I interviewed people in Toronto about this, they came from Halifax, Haliburton, Hanover, and every other town or city without an H that you can think of. And a lot of the reason why they came to Toronto for this summer was because of the concert season. It's warm, you can sleep outside, but also there are services in Toronto that there aren't in their part. So when they come here, they not only can sleep outside, they have services, and they also have the ability to garner funds from such things like squeegee kits. So that's one of the reasons why the summer season, the other 180 days, is significant in its number. And it may be not indicative of the people in the area who are truly without shelter. So I think that's why the biggest reason is that you would take the count when you do. Every semester we would do group work and we would brainstorm how many types of people are homeless. The average was 33 different types. So anybody who thinks that this is a silver bullet solution and there's one solution, guess again. This is a very, very complex issue. One of the ones I would like to make a mention in your, that was very interesting in your report, was the 1 in 3 renovictions. This was not one of the 33 types years ago, and I would submit that's a really big reason why the numbers have been exacerbated by this. That's a significant increase, 135%. A large number of these, obviously a third of them are renovictions, and that in itself could be driving those numbers up. One of the sector types was the economically disadvantaged, and there are many types of people who fit into that. And I think, Mayor Carter alluded to that, where the economics of it, too much month at the end of the money. And if you've seen, all of us have seen the price of food in the last couple of years, it's obscene, the increase. Anyway, so I'll leave that alone. One question I did have right at the start of the presentation, you had the acronym VAW shelters, and I'm sorry, I'm not familiar with that. Could you tell me what that VAW means?
Yes, it's violence against women.
Oh, thank you. Well, that's one of the 33 types too, so I'm not surprised, but thank you for clarifying that. The 19% where it said, locations, 45% emergency shelters, 33 unsheltered spaces, 3% transitional. For the 19%, which is a significant amount, would those be the couch surfers and the people sleeping in vehicles, or are there other reasons for that?
We believe so, although it didn't ask. So you just answered where it was, and that was it.
Yeah, because, when we first had tent cities in Oshawa, I started the GAP committee with Daniel Cullen, and the first year I said, how many people are homeless in Oshawa, Daniel? He said, well, it's either 89 or 91. I said, well, he said, because there's a couple that are in and out of perilously housed. And then it went up to 383 when the Syrian refugees came over and they cleared out a lot of the homeless shelters in Toronto. A lot of them came to Oshawa. So when we did that, in the winter, it was really, really cold. And surprisingly, when Durham Regional Police checked on these folks, there was nobody in the tents. So they found places indoors to couch surf when it was cold. So I think that maybe is part of it. So where's my next question? So the refuge in Oshawa, I'm just wondering, 26 beds, expanded services, what kind of an impact would you see them having in the youth sector of your statistics?
So we've already seen an impact with their beds that they've opened. In addition, we do work closely with those youth serving organizations, and we have a coordinated access table. So we do work closely and bring the three organizations together in order to really address youth experiencing homelessness right away. So that
Yes.
involves Boys and Girls Club, as well as the Refuge and Durham Youth Services. So they meet bi-weekly and actually target our by name lists for any youth who are new to homelessness. Does that answer your
Terrific.
question?
Yeah, it does.
Okay,
That's perfect. Because, I mean, the sooner you get somebody into this type of service, the less likely they are to associate with, shall we say, the less ethical aspects of our community, which pull them into a lifestyle. So
Yes, we do try to target them quite early.
thank you. That's huge. One thing about the Refuge, there's a professional musician that's just relocated to Oshawa, and I set him up with the Refuge. He has Macintosh GarageBand software, and they're setting up a whole music creativity thing for the youth, and it's just another way for them to get. Anyway, I digress, but that's really an important development. I guess perhaps the last. With respect to, there's some comments lately about the value of a social services hub versus not a hub and spreading it out. What are your views on that? Because at one time, if we have so many people with mobility issues, it was taking them an average of 2 hours and 43 minutes a day, 12 months a year, just to try and get what they need to survive in a day. And I'm just wondering what your thoughts are as hub, no hub. What are your views on that?
Do you have the expertise to even answer the question?
I can. I did work frontline in Backdoor Mission.
Happy if you deflect to somebody. I'm just asking,
Yeah,
generally.
I don't want to put somebody in a position where it's like the opportunity and ability is not to be able to answer that.
That's fair.
Yeah.
That's fair. We can maybe get an answer for that offline.
Yeah, we'll get it offline for you.
Thank you. I
Thank you.
appreciate that. Let me just see if I've covered all my types here. Oh, and the last one. When we talk about the number of males that are homeless as a larger sector, I mean, Mayor Carter brought this up. One of the biggest reasons are the economic reasons, besides being criminals on the lam, and more criminals tend to be male than female. Immigrant dodgers tend to be more male than female. And economically, there are those who are under a large amount of, shall we say, child support payments, who are delinquent dads who just choose to bail rather than work hard and support their family. So that's another reason why there are a lot of males out there. The last thing I think Mayor Carter mentioned about extended families, or rather why certain racial groups or national groups in our society have lower incidences. Most of them have extended families. And usually when families come to Canada as an immigrant family, they tend to stick together. So they tend to support each other within a household. So I think I've covered off all my points and questions. So thank you very much.
Thank you.
And Dan, I hope I answered your question.
Thank you, Councillor Kerr. Councillor McDougall.
Thank you, Madam Chair, for allowing me to ask questions. My primary reason for raising my hand was there was a graph up that said, or a chart up that said primary source of income for homeless individuals. And when I totaled it up, they were all social support systems. And when I totaled it up, they were, it totaled up to 97%. None of the primary sources of income were from employment. So does that mean that there's 3% of individuals who are homeless who are employed or some form of employment?
So that's a great question. Actually, so the participants were able to select multiple options. And so that's why you're getting the total of 97%. But we had a variety of other income sources as well. Some them just making their own money or borrowing from family. But the highest number of responses came for social assistance supports.
Sorry, I'd just like to add as well, it's important to remember that the point in time count is really a snapshot of unsheltered homelessness. So when we're seeing individuals who are employed, they might have access to maybe residing in a hotel that they are funding themselves. There's more of a chance of hidden homelessness when there is employment involved as well. We do have some individuals who are employed currently in our shelter system as well, but this is just one of the tools to measure that. So if that is something that you're interested in, we can get you more numbers from our by name list as well that might give you more information on the number of people who are employed currently as well.
Okay, thank you. It was just a bit of confusion for me in terms of like in the list, there wasn't any option for an employed individual, or that's the way it appeared. A follow-up question was with regards to Mayor Carter captured it in terms of one check away from being evicted, one rent check away from being evicted. And my question is around in our shelters, do we tolerate drugs, weapons, sex trafficking, or anything? What happens to that individual should they partake in those?
I think we're going to put that to Lisa for that question, because I think that the answer is if there's any type of action, each one of the shelters I know of, they're asked to leave.
Well, there's varied and triaged responses to incidents that occur based on the individual occurrence. So none of our shelters allow for drug use on site, like in the shelters. None of our programs do. And if somebody were to be on site and overdose, that is not an immediate distance from the program. Many times individuals arrive on site, and then the overdose symptoms and onset is actually after they enter the facility. But yes, there are no weapons, drugs, any illegal activity is not allowed within our service provision. And so that is managed in a triaged manner with the service provider to ensure that we are working with people to have a roof over their head.
So my follow-up question is do you think that individuals who have a nanny suite or an access or an additional dwelling unit as part of their home, do you think they're encouraged to rent to an individual knowing that they're not protected through the Landlord-Tenant Act, such that should the rent payment be missed, such that they can carry on with doing drugs, bring in weapons, etc.? Would it not be advantageous to have it such that, I mean, I know a number of people who will not rent their accessible dwelling units because they're afraid once they're tenanted, they will not be able to get an individual out. And I'm just thinking it might encourage the pool of rentals should people renting their accessible dwelling units, or sorry, additional dwelling units, have the same abilities that the region of Durham does or our associated providers do in terms of those requirements.
Through the chair, if you're asking about the Landlord-Tenant Act and those components of legislation, that would be need to be directed to those areas and that level of government. If you're asking about our shelter program, so in a shelter program, someone is not deemed a tenant. There's not a rental agreement in place, and so it is a different service agreement that sits with that program, and things are monitored very closely. We connect with our legal teams and ensure that we're not falling within that under the legislation that deems a landlord-tenant relationship.
Very good. That's all. Thank you.
Thank you, Councillor McDougall. And thank you very much for the presentation today. I think there's a couple of takeaways just that potentially could be asked, and as we're advocating for future change within the PIT count, and it's looking at a confirmation of the date and timelines, but also additionally looking at if there's any mechanism to add additional questions as the PIT count is being done, and those who are homeless, and having a little bit more information to bring back and deliver to us as well too. But thank you very much for this.
Thank you.
So members of committee, just prior to going on to the next delegation, I just want to remind that this is Seniors Month. June is time to celebrate our seniors of our community and to honor our older adults across Durham's communities. a population that represents over 144,000 residents over the age of 65. I want to take this moment to acknowledge these residents for their valued talents, experiences, and leadership, and express gratitude for their lifelong contributions. The following presentation will be speaking to some of the needs within our seniors community, but I think it's very important that we look at programs and be innovative in how we can support the improving of quality of life for our older adults. So Mr. Malash, if you'd like to come forward. And good morning.
It's still morning.
It is.
I feel it's
For
a
right
mid-morning
now it
stretch.
is. Right now it is.
Thank you so much for having me here today. It's actually really exciting to be able to talk to you about some of the work we've been having regionally, and those of the staff, other councillors, you yourself, your worship, and of course the commissioner. You may have heard this before, so I apologize for the pony show that I've been on for the last little while. I'm here to talk about care for those who are living with frailty in our community. And as was just mentioned, what we are refraining or trying to refrain to do is to refer to aging as a diagnosis or a malady that people suffer from. At Community Care Durham, we have over 900 volunteers who are 63 years of average age. They are active members of our communities, and they are seniors. So seniors, being old is not a disease, thank goodness. What I'm here to talk about is two different groups. Are people who are older adults who want to maintain their wellness, and older adults who are living with frailties that may reduce their independence. I'm also here not out of the blue, not because of a government policy, not because of some dictation that it was given to me, but it was partly because of members of this community who came together last October in council rooms in Ajax through the councillor Dyes, who spoke about we need an alternative to institutionalization of older adults in Durham Region. The amount of reception and positivity that I've received from community residents around these proposals has been overwhelming to me personally, and the support we've received so far from our regional councils, the municipal councils that I've had the opportunity to present to has been very humbling. So I'm here today to kind of walk you through our proposal. We are not asking for funding, we are asking for allyship. And we're asking for a strategic partnership to begin a bigger conversation about creating Durham as a truly great place to grow older and raise families and to age. So here, I'm going to talk a little bit about comprehensive primary health care. It's not just primary care, but it's where people get their first care. It may be a social worker. It may be a personal support worker in the home. It may be their pharmacist. It can be anyone who has regular contact with that individual. And what we look as primary care is being where people live and where they receive their supports. We want to establish a collaborative and innovative partnership within Durham Region, with Durham Region, around how to look at new areas. And two areas I want to focus in on: NORCs, Natural Occurring Retirement Communities, and the other one, which is specific to Community Care Durham, which is called One Connect. So just to throw a little bit about us at Community Care Durham, many of you know who we are, but our mission is to support people and to strengthen our community wherever people call their home. It's about maximizing people's independence and the quality of their life. And I was interesting to hear through the previous presentation around homelessness, I would gather that the greatest or the fastest rising percentage of homelessness in this region will be older adults, without a doubt. Because when you look at the cost of living independently, it is outstripping people's ability to pay. People are being kicked out of retirement homes, people are in hospitals, people are being put in long-term care homes simply because they can't afford to live in their community anymore. We have a 48-year-old history now. We serve almost 10,000 clients across every region of Durham. Our clients are ages of 16 to 106, and we support many aspects of their health and well-being, from personal support care in the home, to transportation services, to food security, to their mental wellness, to caregiver supports. We have 340 staff that are deployed across the organization, caring for people every single day in Durham Region. So what we want to talk about is reimagining aging in place. Now, I like to share stories. This is Anna. Anna is a member of our adult day program in Pickering, and she came to Canada a few years ago with her husband, who quickly passed away as soon as he arrived in Canada, leaving Anna alone in the community with no supports. She came to our program distraught, in tears, a sense of helplessness, and now you can see with a smile of her face, we brought her back into community where she has a purpose, she has friends, and she's being engaged. Anna is living the best life that she can live based on Anna's goals. We want to look at the population, and this is not a scientific, epidemiological map, but I just want to give it from a perspective of how we look at health and social services. At Community Care Durham, we believe that primary care through family physicians or nurse practitioners should be the basis of the healthcare system, not the hospital. I'm going to talk about NORCS, which is how do we keep people well living in their community, which is what most people want to do. Home care, which is we know is people coming into the home, receiving services for a period of time. And then what I'm going to refer to as One Connect, which is those individuals who are eligible to go to long-term care where they've outstripped the needs their needs have outstripped the provision of home care services. And finally, long-term care, which as you know, as you are providers of long-term care in this region. So NORCs. NORCs are naturally occurring retirement communities, and they happen to be wherever there's 30% of the population that's over 65 resides. They can be both vertical and horizontal. So they could be in a community like Parkview in Oshawa, or they can be in a tower like Sunrise Seniors in Oshawa. I just got this data. This is fresh off the press. There's 8,800 seniors living in NORCs across 84 buildings in Durham region. And they have a higher percentage of chronic disease and visit emergency departments higher than they do elsewhere in the province. This data came to me from the UHN Health Network, who is leading some research on NORCs across Canada. So this is just fresh off the press. It's on my phone. I just quickly memorized the numbers. We have people aging in place in buildings where there are no supports. And what we do at Community Care Durham, and many of us do, is we hang up a shingle and say, if you want exercise and falls, if you want Meals on Wheels, come and find us. We're out here somewhere. And what we hear all the time is, we had no idea you existed. We don't even know it's available in our community. And what NORCs do is they put coordinators in buildings to help facilitate community or resident-driven solutions like activation programs, card games, dancing nights, to keep people connected into their community, if people are well, and people are happy, and people have purpose, they'll maintain their wellness. What I'm going to talk a little bit about tonight, and just to go back for a moment, I believe this should be, we need to reimagine aging in place through the lens of NORCs. Let's meet people where they live and design services around what they think are important to them, rather than what we do, which is stand outside and say, come and find us. And so I encourage the Durham region and the staff of Durham region to really, and we've met, some of us have met on NORCs, of how do we adapt this philosophy more broadly as they are doing elsewhere in Canada. So I'm going to go to One Connect. There's a term here. This is not people who are frail. I won't refer to frail people. I will refer to people living with frailty. There's a significant difference because frailty is reversible. And what is frailty? Those are people who have a combination of health, physical, mental, social, economic, or cognitive challenges that are combining to create a mix of risks that they might lose their independence. So for example, take an underhoused senior or someone who has lower financial means. When they're given a prescription by their family doctor to manage a hypertension, but they can't afford groceries or they're barely able to afford their rent, what is it you think they're going to stop taking? It's their medications. Frailty is reversible if we look at sometimes the healthcare problems we face are not requiring healthcare solutions. They're requiring social solutions or economic solutions before we can address the healthcare ones. And so in Durham region, there's roughly 27,000 older adults who are living with the combination of what we call frailty. And those are people who are most likely to end up in our hospitals, end up in our systems, looking for supports, because I can tell you from, if you ask many seniors, maybe you can think of your own parents or your neighbors, older adults are not looking to seek help. They think they're proud, they want to maintain their independence, and they're always thinking that someone else is worse off than I am. The truth is, they're worse. We need to find those people. So in Ontario, what we have, and this is global, is that we have a system that's focused on whatever your diagnosis is. If you have a healthcare problem, you go to the healthcare system. If you have a social problem, go to a social worker. If you have an economic problem, go to an economic support. But there's no system that addresses frailty. And in fact, our healthcare system sees people as transactions rather than like whole persons. I'm paying a home visit to you, I come here, I do this, and then I leave. And then I'm gone. And I don't really care about what's in your fridge. I don't care about how you're paying your rent. I'm just here and I'm gone. We are not addressing those social issues. Our healthcare system, we're not helping our individuals navigate that. And so we have the most complex individuals and their families navigating a system that is not designed for them. And the burden on caregivers is incredible. We have people who don't even know who's coming in their home. They don't even know the agency that's in their home, or they don't know where to get the support because it's a complex system. So here in Durham, sorry, I actually step back for a moment, and I use this quip. I'm sorry if you've heard it before. I have found no one on LinkedIn that says their career goal is to retire to long-term care. No one, zero in Ontario, wish voluntarily to move to long-term care. And when they're ill, 90% still say, I would rather stay at home. But we're treating long-term care increasingly as a first option. And I don't mean this is not a criticism of long-term care, and my colleagues in the room here, is that this government in particular, we're focusing on building long-term care without investing in community supports. And in Ontario, in Durham, that will not meet the demand. We have long been the youngest region, one of the youngest regions in Ontario, but we're now the fastest aging population in Ontario. Other communities like Kawartha Lakes, Northumberland, as you know, I've worked in government, I'm aware of the data. They've always been old. Durham's getting older, fast. And right now, in the next 10 years, demand for long-term care will increase by almost 40%. And in January, there was 2,400 individuals waiting for long-term care placement in Durham region. And most of them, if they're on a non-crisis placement, are waiting almost 600 days. And that's an optimistic number. Some clients are waiting 5 to 7 years to be placed in the home of their choice. Can you imagine for a moment that you are living on the brink of breakout and frustration and all the stresses of your life, and someone says to you, oh, I'm going to give you a perspective. The wait on this phone call is 35 minutes. The Rogers cable person will be to you in 7 days. Oh, by the way, it's 7 years before you go to long-term care. Put that into perspective. People are being asked to carry the burden of a broken system, and we have no solution for it. No one wants to wait. They can't even, when someone says, when's the Rogers person coming? Between 2 o'clock and 6 o'clock. Like, could you be more specific? But this is how we treat our healthcare system. We want to do better, and I believe at Community Care Durham, and I believe in Durham region, we can do better. And that vision is called OneConnect. We've looked at programs in the United States called PACE, the Program for the All-Inclusive Care of the Elderly. It's a capitated model where people are enrolled in a single program with a single budget that weaves together their health and social needs and navigates that person. Everyone on that team is supporting that individual to maintain their independence in their own home. And we believe we can replicate a version of that here in Durham region. And this is the vision. Around a client and their family is bringing together their home care, through providing community nursing, community pharmacy, physical activation and restoration, and physical rehabilitative services, adult day programs, transportation services, food security, and social work, in one single program. No barriers, no silos, all within a single program. And we are calling that One Connect. We are prepared and ready to do this. We have grown over the 48 years. We are more than Meals on Wheels. We are more than transportation. We serve every single day 350 older at-risk adults in their home every single day, and sometimes we're in that home 4 times a day. We have now been, we started on our own funding a community nursing program when people told us we shouldn't and couldn't, because we saw in our buildings people aging in place and they were falling through the cracks. A simple urinary tract infection that, when undiagnosed, leads to a hospitalization or ED visit, which for an older adult can be very traumatic. We are now serving Lake Ridge Health by having our staff 7 days of the week working in emergency departments. And so far, since October, we've taken 290 people out of the emerge who had otherwise been admitted into hospital. And we're now taking them home for 4 weeks of care and giving them a care plan. And we developed a business architecture that allows us to track cost and outcomes so that we're an efficient organization. But more than that, more than all of those things, we are an organization that's committed to the vision of seeing people as people and providing them the care that they require, whether it's healthcare or social care. We are committed to this vision of One Connect. So much so that during the height of the pandemic, we purchased our own building on Sunray Avenue for $4.7 million and asked for no new funding from the government. And we are now in the process of issuing a tender for construction to renovate this site in Whitby to be a home away from home, where people will come into our program, have adult day programs, see a nurse, get their hair done, have laundry services done. Caregivers can actually meet other caregivers. There'll be mental health and wellness groups in one single center. And we want to show that this is a model that can be replicated across Durham Region. And in other words, think of it as a long-term care home without any beds. That's our goal. And we're really excited to have this up and running in about a year's time. It will be the cornerstone of One Connect. Many people don't understand the value of a day program, by the way. There's a stigma attached to it, frankly. They think it is daycare. That's a pejorative way we describe it. Day programs, and perhaps we need to find a better word for it, provide socialization for seniors who are otherwise isolated. It provides caregivers a break from caregiving. It provides them to meet with a nurse, have nutritional supports, do cognitive and physical stimulation, rehab services. And every one of that team, I just give you an example of the people we might pick up every single day. So we have a Community Care Durham driver who will pick up a client, take them to a day program. They spend from 9 to 3 with us, and then they go home. And the driver is a part of that care team because now they're talking with the recreationist, the personal support care worker. Everyone is aware of what's happening with that individual. But I can tell you that one of the most uplifting conversations I've had about the day program was the impact for the caregiver. This woman, I was at a Rotary meeting, as Mayor Cotter said, and a woman came up to me, she said, my husband was, when he was still alive, was a part of your day program. And he loved it. And I asked why. And she said, because he thought he was going to work every day. He worked with the staff and felt they were his employees, and he was giving directions and he was helping out. This gentleman had dementia. And when they went home at night, they talked about what work was like. Think of that personal relationship between a husband or a spouse or partners that can be worn down through the burden of caregiving, where we give that caregiver a break and they can re-engage in that relationship in a positive way. The relief that brings to families and to people is incredible. So it's not, we have a client, but we have 3 other clients that are part of our day program, and they're not even in our program. They're at home. They're doing their things. They're going to work. So what we wish to do, we have submitted a business case to Ontario Health, who is our funder, to support this vision of One Connect for 150 clients, which is the alternative to building a long-term care home in Durham Region. We are asking the government to fund the capacity of long-term care without building another home. And we have the tools to spread this across Durham, and we have the interest from other partners to spread this across Ontario. Many organizations have reached out to us and said, what are you doing? How are you doing it? How can we get involved? This is an opportunity for Durham to put a flag on the ground and say, we have made a made-in-Durham solution that is scalable for Ontario. And when I met with the Minister of Finance through the Ontario government, they are excited about this. We have the support of all of our MPPs on this proposal. We need your support, but more importantly, our residents need our support. And this is a time for Durham to step out and do something revolutionary. This is the proposal. We're not asking you for funding. The rub of it is, this program supports an individual for $90 a day versus over $201 a day for long-term care. And you know what's included in this? No subsidy for no client fee for any program. Transportation to any medical or social services. A $3,000 social prescribing budget for every client if they need help paying their rent, buying medications, extra food. We have dollars that can be driven by the decisions of that client and their family to help them maintain their independence. This is a cheap and effective alternative for our taxpayer, and it actually creates better outcomes for the people that we serve. So again, we need your support. Not just a motion or some indication to our funders that we have the support of Durham Region, but we would like to continue working and planning together around NORCs and around models like One Connect. We think there should be, as we look at future growth in this region, how do we plan for places where seniors and older adults can age in place with the facilities that are worthy of them? I had a chance to visit, thanks to the commissioner. I went to Peel to visit their program. It would blow you away what they're doing in Peel for older adults. And I'm asking myself, as a lifetime Durham Region resident, why not here? Why not here? We're also, and I know this is maybe not on your radar yet, but we have met with staff to look at Fairhaven Long-Term Care to bring a day program into that program. And I know you're going to be asked, or someone will be asked somewhere along the line, with a financial request about how do we renovate that so that we can lease it from you for 10 years. Because we need to expand day program services here in Durham Region. So there's many areas where we need your support, but mostly what we're looking for is allyship in creating a new vision for aging in place in Durham Region. So thank you so much for your time. I'm happy to take any questions through you, Madam Chair.
Thank you very much, James. Mayor Carter.
Madam Chair, thank you very much. James, always a pleasure to see you, and thank you for your work, not only on this, but the work that you did on behalf of Ontarians for many years in regards to healthcare. Are you looking for a letter of endorsement from us in regards to supporting this concept?
Yes, that would be helpful.
So I'm wondering how that may be, if the committee is comfortable with it, and of course, I mean, I honestly look at this and go, like, I'm a little envious of Whitby because you're getting one, and I think it's wonderful. That also opens up an opportunity. But I'm wondering is there a comfort level in regards to us endorsing it, or does it have to go to council for endorsement?
Or you want a motion direction? Okay, yeah, no, 100%.
So, to move a motion to endorse the concept of this program and ask for council support. Is that fair?
Following the other questions, we'll come back to you for the motion, and I think it's completely fair. And I think that just that number one, he's only asking for a letter, not money.
Yeah, no, no, but I mean, I think dealing with the province or Ontario Health, having a letter of endorsement from the region would be beneficial in regards to it, and I think that would be helpful. So I just wanted to try and make sure we do that. James, I'd also extend a hand to you to be able to maybe you and I contact each other and chat about it. we have some interesting partners in the city of Oshawa that I think with new development may be interested in a program like this, because they're looking at also bringing like loft community services into new builds. And I think that we could incorporate something that you're talking about. So I'd encourage us to get together, okay?
Thank you, Mayor.
Fair enough. Thank you. Thank you, Madam Chair.
Thank you, Mayor. Is there any questions from committee members? Okay, I'm going to turn to Councillor Kerr. Oh, Councillor Dyes first.
Sorry.
That's okay.
Slow on the button there. Just some questions about funding too, and I know this is a great program, obviously. I think it's much needed. And I also think that there's an advantage here for the province of Ontario and the healthcare system, and maybe you can support that too, in that there will be some advantages of saving money, and particularly in the hospitals, where we'll see more and more beds become available when the overall health of our seniors is much better.
Well, absolutely. I mean, we've been fortunate enough to receive support from Lakeridge Health, from the Durham Regional Ontario Health Team, from many other groups, from the Seniors Care Network. We've been building a case for change and have been receiving that support. And I would suggest that where I think long-term that partnership with Durham Region comes in is how we bring together our health and social services in a more strategic way, that where we deliver it in a more coordinated fashion as partners and collaborators. So that's where I think the NORC conversation is very important. We run programs. Durham Region runs programs, but are we running them in a way that actually is easy to access and is coordinated for people that makes sense to them? As far as the saving dollars, I mean, listen, when I started in the Ministry of Health, it's been a while. And I think our budget was somewhere around the area of like $29 billion. And over the course of my career, it's approaching $90 billion. We have to find alternatives. And, if you think about people who are of the generations just below us, they will not have the income that our generation has and those older generations have, because they owned homes. There's a large part of our population that will not have the financial security of home ownership till much later on in their life. And what most people are doing now to afford their retirement is reverse mortgaging or selling their properties in order to pay for their health care. We need to be prepared that this generations that are coming with us have different sets of expectations. They do not want to be institutionalized. They want to live well as long as what they can. They want their independence, but they might not have the financial means that we have enjoyed to, live in a retirement home, for example. So I think we have to start to really wrap our head around is, what does aging look like? We know it's here. It's been here for over a decade. But what does it look like in the next 10, 20 years? It's not going to be the same.
Well, I agree, and I think we don't really look at aging. We've set that group of people aside, and I think there's impacts also financially on families who are now taking the responsibility of looking after aging people. There are many, many women who give up their jobs and their income and now live in poverty for that reason. So there's a lot of good things that can happen through a program like this. I think it's very beneficial, obviously, for seniors who are aging. I think the worst part of it is the mental health, in that they are not able to socialize.
Yes.
And I think that's a key component to their overall health. So it's an amazing program, and I think much, much needed change. As a person who's looked after 4 seniors in my family, I know where the gaps are. The hospital system isn't there to meet your needs either. But yeah, I think this will make a huge, huge difference. I like the way the funding formula is around it, where it's not separated for every different part that you are going to access. It's an overall funding. So yeah, I'm really happy. I'm happy for you getting it in Whitby, and I know that it will progress, and look forward to that. Thank you so much for what
Thank you
you're
for your
doing.
leadership. Right.
Thank you, Councillor Dyes. Councillor Kerr.
Thank you, Chair, and through you. James, I absolutely loved your presentation. Not that I didn't like the others today. They were different and equally effective. There's so many things that resonated with me about this. So first of all, the NORC, would you please, I'm not great with acronyms.
NORCs, naturally occurring retirement communities.
Bingo. So thank you. So where are these and how do they develop? Because when I think of a retirement community, I think of, Taunton Terraces or whatever they're, and you see a big brick and mortar building and everybody lives in there and pays $7,200 a month. So where are these and how do they develop?
They develop through nature. It's like just to give you the data, there's in Durham, there's 19 apartment buildings. I actually happen to live in one in Whitby, 50 condos, and 15 seniors residences. So this is where the population crosses a threshold of older adults. And so they exist, they occur naturally, where people just decide to move, retire. That does not include retirement homes, and does not include long-term care homes. These are just where people are living. So we actually have addresses for these places. And I'm sure community paramedicine would probably know where a lot of these buildings are. I can think of Mary Street. We've been in 155 King and Oshawa. Like those are also NORCs. We just don't describe them that way.
Yeah.
But I also live in a building where in my building, there's 35% of the residents in my building are older adults. And the management reached out to me and said, well, how do we bring transportation and other services here? They just happen to know I'm the CEO of Community Care Durham. So I think there's a number of buildings across Durham region, and we've had some preliminary meetings with Durham regional staff. It impacts everyone, even regional transit, looking at transit lines and how they're designed to meet the support of access to services for these communities. So they're there, Councillor, and I think it's maybe a way of reframing how we deliver support.
Sure. Okay, and thank you for that. I get it. And how does the LOFT program fit in potentially to something like this?
Well, I mean, the LOFT program, those are supportive housing or assisted living types of programs. They would naturally bring people together and probably create an NORC just by that nature. So, for example, we support Sunrise Seniors buildings in downtown Oshawa, both towers. We've just called it supportive housing, but it's actually a NORC. So when you put supports in place, you're naturally going to start to create NORCs because of the population that are coming into it. But we know there's many buildings here where there's no service. They're just people who are again, finding a home. So what LOFT and those other programs are, those are designed programs. What we are thinking about is how do we keep people from actually needing healthcare? Like this is not about delivering care, it's about delivering social services and connections. And what the data will tell you is that people who are in a NORC will receive up to 30% less home care and have fewer visits to their physician because they're doing the things that are keeping them well. Yeah. Have you watched the Blue Zones? Has anyone watched the Blue Zones? I would say the 2-3 things that stood out for me is that people have community and purpose in those Blue Zones. And the second thing is they're actually moving all the time. It's not they're not going to exercise classes, they're just walking. I just came back from Lisbon and Portugal. Walking through Europe is hard. It's hard work. It's up a hill all the time. But this is just getting people out and moving and getting them out of their apartments, meeting with other people, going for walks, playing cards. We're actually having a meeting with some folks downtown Oshawa, Parkview, to say, hey, listen, how do we create a NORC here?
Yeah.
So this is just where people are living.
Thank you. Lisbon has been there. Lots of work.
Yeah.
You mentioned about taking a look at a spectrum of factors that may together negatively impact a senior. One of those is being over-medicated. I mean, she's not a senior, she's a niece. When she got a new doctor and they evaluated all the medications she was taking, he said, why are you taking all these? When they did that, she lost 60 pounds in a healthy way. So, there's another factor that impacts, sense of esteem, well-being, and is over-medications. So when you make your presentation, I'm wondering, I didn't quite get this clearly from what you said. Have you considered taking a look at a list of savings that a program like this, and you alluded to it, would create elsewhere in terms of fewer hospital visits, fewer PSW visits, fewer handy trends, utilizations, et cetera. If you thought about where all of those, making an actual list of a spectrum of cost and range of cost that you could actually positively impact the healthcare system if you did this.
Yeah, we have what we're calling key performance indicators, KPIs. They include financial savings and efficiencies. They also include issues around satisfaction or self-reported wellness and connection to community, as well as falls, ED visits. So it's a broad range of indicators. We are working and have reached out with several academic partners here in Durham, as well as in Windsor and McMaster and Toronto, to bring a research element into our work to look at some of the questions around access outcomes, financial outcomes, health outcomes, because we believe this is an area for research. Just on the cost alone, we can identify savings.
Okay.
Yeah. And I will tell you, because of the data we have at Community Care Durham, we track every individual based on their healthcare need and their 911 calls and their hospital days and their hospital visits. And people in our assisted living program will have far fewer 911 calls and ED visits because they have a care coordinator they can call 24/7 and have someone in their home within an hour at any given day. That's very vastly different with how home care is operated now in Ontario, where you have to get in line, get an assessment 5 days later, maybe someone comes to your home, maybe they don't. And, and so what we're seeing, and we did the study at 155 King Street as an example, is that how many of our clients are using the 911 call, and our clients, much fewer. Last little point, the family physicians we're partnering with the Durham Ontario Health Team right now, and I know one of my partners just left, is that family physicians are so excited about this program because if they know that they have eyes and ears out into the person's home, they feel like they can actually help, they can do their work. So we've been committed that anyone we bring on the program now through assisted living or OneConnect, the family physicians in our community said they will, if they're unrostered or they're unattached, they will roster them immediately. So none of our clients are unattached to primary care because they're supported in the community. That's a huge win for everyone.
It is. And I guess my last point was in terms of affordability, which I thought was an extremely important point. My mother-in-law, who unfortunately is now no longer with us, her monthly rent for living in a villa, I won't say which one, was $7,200 a month. And it was going to go up, the next person in there would be paying over $8,000 a month. And there may be some people who can afford that, but there are a heck of a lot who can't. So the thing that resonated me likely as much as anything else was how people can remain situated where they're comfortable, where they have some social connections, and we just need to tweak their life factors so that they're healthier human beings. Thank you very much for being here today.
Thank you, Councillor Kerr, and there are no more questions. I do want one clarity before I turn over to Mayor Carter for moving a motion for receiving a letter of support for this programming. But I also believe that there's a point too, and that's a working partnership with the region of Durham as well too, between community care and also with the region of Durham as well too. Is that correct?
Yes.
Okay. So Mayor Carter, are you prepared with that?
Sure.
Sure.
Yeah.
Madam Clerk, are we prepared with a motion for moving forward, or you're okay with the direction and understanding that we are looking for a letter of support? And point two is that there would be an established working partnership between Community Care Durham and the region of Durham. Have a seconder? Councillor Brenner. Any questions? Councillor Neal? I don't know. He pushed it before too, and I don't think he wants. Yeah. All right. Any opposed to the motion? Okay. Thank you very. I'm going to ask for a 10-minute break. Yep. Yeah. Councillor Neal, do you want to speak? Hold on. Okay. Now, please speak.
Does this have anything to do with the Oshawa Senior Citizen Centers?
No, it does not.
Okay, thank you.
Okay, so the motion is passed, and we need a motion for a 10-minute break. Chair Henry, seconded Councillor Anderson. Any opposed? So we will return at 12:15.
Thank you.
Thank you. And first, we're going to start with a roll call. Thank you, and I know that Councillor Anderson had to leave for another meeting. Next presentation is Jessica Clark, Acting Commander of Community Programs, and Stephanie Brooks, Nurse Practitioner for Hillsdale Terraces. Please go ahead.
Okay, so first of all, thank you very much for having us here at the Health and Social Services Committee. So in celebration, of course, of Seniors Month, we would love to share with you a great program within the regional long-term care homes in collaboration with our paramedic colleagues. I am Stephanie Burkus, Nurse Practitioner.
And I'm Jessica Clark, Commander of Community Programs. And here we're going to show you from pilot to practice and how we've been able to partner with long-term care to increase diagnostic testing. So as you can see, project leads for our program, we were one of 6 paramedic services in Ontario chosen for this adventure, and we have 4 paramedics that put their hand up to help support this. They're all community paramedics, and they have over 20 years of experience.
From the long-term care side, a big partner of this program was our nurse practitioners in our 4 regional homes, along, of course, with our registered nurses and our registered practical nurses.
So project goals are to reduce transfers of long-term care residents for diagnostic services, and we're trying to increase the access to diagnostic services at the long-term care homes.
So first of all, why do we want to do this? So why do we want to keep our long-term care residents out of emergency departments? So as you can see on the slide, so capacity of emergency departments aside, sending a long-term care resident to an emergency department has many consequences. So when they're there, they're often there by themselves, so they of course have no one to advocate on their behalf. The risk of getting an infection in the hospital is high, especially in an emergency department. If you're sitting on a stretcher for an extended period of time, you're at a high risk of getting a pressure ulcer, which means kind of skin breakdown on those bony prominences. Again, if you're sitting in a stretcher for a long period of time, your muscles start to get weaker, you start to get at a higher risk of falls. And of course, the risk of delirium is extraordinarily high for our older adults in an emergency department. So that's about 1/5 of older adults that go to emergency ended up with a delirium. So as you can see there, it's not just sitting in a stretcher and being sick, it's that there's constant lights, constant noise, you're not getting fed, giving water, adequate time frames, you don't have your glasses, you don't have your hearing aids, and that can result in a delirium. So we really want to keep our long-term care residents in the home and getting treatment as much as we can.
So that brings us to project details. So the why obviously is explained by Steph, and you understand that the program specifics are really focusing on bringing those diagnostic testing needs to address urgent episodic care needs. So we have point of care blood testing, which is a basic metabolic panel, and a point of care urinalysis machine that'll rule in, rule out a urinary tract infection, and then point of care ultrasound. So looking at your cardiac system, your lungs, your abdomen, and your bladder. And the program outcomes are really just increasing those services to be able to keep them in the long-term care home safely and independently with the staff and family. So this project is funded from the Ministry of Long-Term Care, and it originally was from September until March 31st of this year, and we are excited to say that it has been extended until March 31st of 2026. Got good at that. So when we look at the overview of the program, because everybody likes stats, so let's have a look at these stats. From October 1st to May 25th, you can see the patient care visits we have completed is 581 in-person visits. So 168 of them are scheduled, but majority of them are unscheduled. And that's why paramedicine is helping support, because it's not a scheduled visit. There's a ton of phone calls daily that we're fielding to try and figure out what we can do, how we can help, how we can support to really avoid that 911 and ED utilization. When we look at the middle column, it really focuses on our diagnostic services, and you can see point of care blood work is the majority of what we've been doing at 276 blood draws already. They're getting really good at blood draws over there. Ultrasound is up there as well, 148 unique residents, but each resident sometimes gets 5 to 6 scans depending on what they're looking for. Urinalysis, 87. IV rehydration. This has been a huge benefit to end of life or palliative patients in the long-term care home. They're not eating or drinking. It's that family's last kind of, this makes them feel good and makes the patient feel good. So 76 so far. And then IV Lasix, so same sort of thing, trying to diurese them, get rid of that fluid, and hopefully make them a little bit more comfortable from a quality of life perspective. Cardiac monitoring is up there as well, 120. And you know, when you start looking at all of these calls, so that's 581 visits that we've completed, and out of those 581, only 25 calls ended up being a 911 call. Some of them you have to. Some of them you have to call, and when you break that down, that's like a 0.04% of a 911 activation. So that's huge. Even our 911 frontline paramedics have noticed a decrease in calls to the regional homes that we're partnered with, so that's huge. So first line, for some more stats, this is 911 specific. If you look at September 1st, 2023 to May 25, 2024, you can see the regional 911 calls. And then you can see that there has been a reduction specifically at Hillsdale Estates and Lakeview Manor since this program has started. I'd like to highlight Hillsdale Terraces, that small amount of 911 calls there as well. So it's exciting to see where we can continue to go with this.
So let's bring this into a case. So this would be a common one that would be a great collaboration between our team in long-term care home and the community paramedics. So an 80-year-old male, he's got congestive heart failure. So that essentially means his heart cannot pump fluid effectively around. So we would notice that they were more short of breath as fluid settles in the lungs, or they might have swelling in their feet. So at the home level, I would go see this resident. I can order an oral water pill to try and get some of that fluid off. I can have a chest x-ray that may come into the home in a couple of days. I can order blood work again that may come into the home in a couple of days. We can monitor their vital signs, we can give them oxygen, and we can adjust their fluid intake. But now with our community paramedic partners, I can give them a call. I can say, this is the situation. They can come in and do that blood work immediately. They could do a lung ultrasound if we needed to see if there was in fact fluid on the lungs, and they could give that IV Lasix that Jess had mentioned. So they could put in a little intravenous catheter and give that water pill in a faster affecting form. So, so that's what we did. We asked for that intravenous Lasix to be given to try and take off a bit more fluid than the oral pill. And we did that lung imaging. We didn't have to wait for that x-ray. We were able to do that blood work kind of before and after, which is for safety. And they were able to come back over 3 days to make sure that resident got a complete dose of medication. So essentially, they started to get better over a few days. They showed improvements, less oxygen, less swollen. And as you can see at the bottom, the most important lesson out of that is that we did not need to transfer that resident to emergency when we might have previously had to. So you're thinking of how this is freeing up emergency department space, but it's also freeing up paramedic response time for 911 calls, lowering hospital costs, and it's a lot less money to treat someone in their home in long-term care than sending to emergency for the same treatment. So of course we wanted to know how our staff felt about this program. So as you can imagine, with any new program, there are some growing pains. So historically, long-term care staff did not feel very supported by our paramedic partners. They often felt that when they would call 911, they would be questioned by the paramedics and second-guessed as to why they were calling for paramedics, that kind of thing. So bringing paramedics in the home, that was kind of their feeling. But after we collaborated, we really felt that our community paramedic partners were supportive. They came into the home and they said, we're here to support you. We're not here to tell you what to do. We're not here to question your judgment. We're here, tell us which diagnosis you want to do. Tell me what's going on with the patient. So that approach by the 4 team members was really helpful to get the buy-in of our long-term care staff. And from that hesitation to that collaboration, we then got initiation. So our staff then were the ones calling them and using them frequently and saying, and collaborating and saying, this is what we need from you. And in the end, we have a very kind of successful and supportive partnership. So we left a quote there just from a staff member just saying how much they appreciate having those diagnostics available within the same day or next day, and how they really have loved the collaboration.
So obviously staff feedback is important, but so is family feedback and patient experience. And there's been a lot of positives that we've received, too many to put on one slide. So we just selected a couple there, but you can see that they just feel reassured. They feel comforted, they feel supported, and they feel that their needs are being addressed, and they don't have to take time off work now to go sit with their loved one in Emerge and all of those, right? So I think this is just showing that this is a true collaboration and support, and really, really hope that this is going to continue. So when we look at possible future opportunities, so I think we can identify some things that are working really well as a new program, and I think there's maybe some gaps or some challenges that we can work on together, and maybe some opportunities we can work together with the long-term care homes. Is there an opportunity for us to onboard IV antibiotics so we can get them out of the hospital sooner and back into the home? Can we support that? Is that something we can look at? So we're currently in the process of a reviewing of what this would look like and how much this would, onboard of training and cost and all those things. So we're currently looking into that. And then also looking at IV saline lock flushing. So if we're doing a rehydration or an IV Lasix on a patient more than one time, and it's 3 days in a row, there's no point in us repoking that patient 3 times. We can hopefully leave that saline lock in place, have some of the nursing staff at the homes be trained to be able to flush that, and then we can look at that patient experience and not repoking, right? Rehydration training is huge. It's been a huge benefit in long-term care. And is there an opportunity for us to look at that in collaboration with the long-term care homes, right?
And our last area where we have collaborated, and we've actually collaborated on education as well. So we're giving a similar education training to our staff in long-term care that community paramedicine is getting. So an example of that would be that if paramedicine was called to see a resident and maybe active treatment is not the best choice, and maybe we are looking at more of a palliative and end-of-life focus, we need to make sure all our team members are giving the same information to families, are on the same page with the same goals. So having their staff and our staff at the same trainings is going to just provide that consistency for families. Okay, all right, that's it. Thank you very much. If there's any questions.
Thank you very much, and thank you for the work that is being done. Sometimes the simplest things are the things that we need and help within our, not just within our seniors community, but as a community as a whole. And we don't acknowledge that a simple urinary tract infection can cause so much issues with an individual, especially a senior as well too. Is there any questions? I don't see any, so thank you, and have a great afternoon.
Okay.
So thank you.
Our next two delegations, our presentations have been withdrawn. I am going to call upon Mary Beddoes, Durham resident, and she's from supporting the tenants of Gillespie Gardens to obtain a generator for a Durham Region non-for-profit housing corporation. Good afternoon, Mary.
Not sure which button to push here.
It's on.
Oh, is it on?
Yeah.
Okay. Ladies and gentlemen, I'm here today to ask for your help on behalf of the tenants of Gillespie Gardens in Beaverton. During the ice storm and the blackout, we discovered an issue that became very disheartening. And that issue is the fact that Gillespie Gardens does not have a backup generator. Now, if this was not a senior citizens apartment building, I wouldn't be here, but I am. The thing that we noticed immediately, and it was by the downstairs tenants, was that the building to the north of us, Lakeview Manor, had a backup generator, and that the building south of us, Beaverton Heights, had a backup generator. Now, what's wrong with that picture? Let me see. To emphasize that point, we had 2 tenants, one on each floor, who relied on oxygen. Both of these tenants ran out. The gentleman on the downstairs was fortunate. His grandson came and got him and his equipment and took him to his house where he was able to connect to his generator, and he was fine. The upstairs gentleman, not so fortunate. He ran out of oxygen. So some of us were running around trying to find a phone that was working to get him to his oxygen company, which we did. He got oxygen. But to really tie this whole ugly picture together, downstairs, a 92-year-old lady with breathing difficulty, using a walker, trying to get through fire doors in the pitch black, fell, landed on a previously broken arm. Now this arm, we're trying to get her to x-ray to determine whether she's got a torn rotator cuff. Now these events could have all been avoided had Durham nonprofit put in a backup generator. So while I was doing my research and my homework, discovered that Durham Nonprofit's building in Cannington, Allen's Place, had exactly the same issues. Now, it's not saying that nonprofit didn't do anything. They came in on days 3 and 4 with tea and coffee and donuts and sandwiches and soup. Now again, we pay our rent, but we are treated very poorly by nonprofit. They do not respond to our concerns, our questions. They seem to be more interested and concerned with their pay raises and their bonuses. So that's why I'm here. I asked Brock Council to support us. I'm here to ask Durham Regional Council to support us in getting Durham nonprofit to get a generator into the building. The weather is not going to settle down and behave like it did 20 years ago. We are going to have more issues of severe storms, severe winters, severe everything. And the seniors that are in these apartments are not going to be able to tolerate it. We are 2 floors. The elevator goes out. There's a guy in a wheelchair. He can't get out of the building unless he's already out. There's tenants up there that have walkers. They can't get downstairs. Those of us that are younger are running up and downstairs, making sure they're okay, making sure they've got tea, coffee, sandwiches, whatever. And that those that don't have any family right handy, that they're okay. But what happens when we're not there? Durham Nonprofit doesn't seem to give a rat's ass whether we're there or not. So that's my plea, folks. Please help us. We are 66 apartments of seniors that need somebody to help us get nonprofit.
Mary, thank you for your presentation. You said you spoke to and presented to Brock Council.
I did, yes.
And I know Councillor Jubb is going to speak momentarily.
Yeah.
Have you spoken to Durham Region Non-for-Profit Housing?
During the 3 and 4 days that they popped in with sandwiches and soup and whatnot, we asked why we couldn't have a generator. Well, you know, it's really expensive.
Okay.
That was our answer.
Okay.
On 3 different occasions.
So I'm going to preempt, even because I just sent a message over to Councillor Jubb as well too. We actually have a board meeting tomorrow morning for Durham Not-for-Profit Housing, and it's their operating budget is the one that has the oversight with your building and the other building you spoke of as well too. I'm going to allow Councillor Jubb to go forward, but I think that we will take that direction and just bring that over to Chair Foster tomorrow and also to the Executive Director, Tracy Grieg. So Councillor Jubb?
Thank you, Madam Chair, and yes, through you to Mary. Hi, Mary.
Hi.
Nice to see you, and thanks for talking to me this morning on text as well. So, yeah, I was into Gillespie Gardens during the ice storm, and I did experience the challenges as well. Can you just confirm how long was Gillespie Gardens out of power for, Mary?
We were out 4 days.
4 days, okay.
4 days.
And I know talking to the fire chief, he did make that a priority to get a lexicon to try to expedite getting to Gillespie Gardens as well as the manor.
Yeah, and then we had a power outage again last night when somebody somewhere hit a pole and we were out again for several hours.
Yeah, that was going to be my next question. I was also out until about 2 in the morning, so, and Gillespie Gardens was out again then?
Yeah.
Okay, that's unfortunate. Okay, the chair did recommend getting this in front of non-for-profit housing. My only concern is I'd like to show somehow our committee support. So back to you, Madam Chair. How can we show our support before the meeting tomorrow to non-profit housing?
So the only thing that I can actually state is that because they're a separate board outside of us, that the direction, I think that we just expressed that there's a need to give the support, especially with the backup generator. And what can the board, like what can Durham Non-for-Profit Housing come back with? And through ourselves and Chair Foster, because I'll give him a call as well too and let him know that this has been raised at this committee today, and have it part of under other business tomorrow to look at how we can work through this situation.
Thank you very much. I
Okay.
appreciate it.
Okay?
That
And
works.
I'll
That
follow
works
up
for
with
you,
you,
Mary?
Councillor
Yeah.
Judd, too.
That works
Okay,
great.
thank you. That's all.
Thank
Okay.
you very
Perfect.
much,
Thanks.
You're
ladies and
welcome.
gentlemen.
Thank you. Next, moving on, we have no correspondence reports. I need a mover. It's appointing an acting medical officer of health, moved by Chair Henry, seconded Councillor Brenner. Any opposed? Councillor Carter or Mayor Carter?
No, in regards to the next one.
Okay, so under the correspondence, you want to?
Yes.
Okay. Under the correspondence, Mayor Carter. Oops, push it again. No.
I know I've talked a lot. Instead of receive for information, can we refer the correspondence to Durham Regional Nonprofit Corporation and their board for a response directly? Is that appropriate, Madam Chair?
We can absolutely, but it is addressed to Tracy. But we can send it forward, 100%.
I just would rather it be referred to that than receive for information, that's
Yeah.
all. So,
Yeah, referral's fine. Seconded.
thank you,
Councillor Brenner.
thank you.
Any opposed? Next, moving on to the reports. I'm gonna now look for a mover for both unless there's pulls. Moved by Mayor Carter, seconded Councillor Brenner. Any pulls? Any opposed? We have no committee resolutions, confidential matters, other business. Mayor Carter.
Thank you, Madam Chair. I did let the commissioner know that I was going to share this information today, so it won't be a surprise. I thought it would be appropriate based upon all the information that we have discussed today and the reports that we have, that I wanted to share with this committee a typical week in Oshawa, if you don't mind. This comes directly from all of our departments. We have a security call every Tuesday morning where all the data is collected and shared. Our data for May the 19th to the 26th, our total responses in regards to the unsheltered population was 2,057 incidents. Our cost in regards to dealing with the issues associated with that, based upon our data, was $84,944. The three different categories that fall within that 2,057 responses is associated in regards to the unsheltered population, 1,649 incidents with our rangers and works teams that include human waste, cleanup of encampments, large items, and debris. Also, 67 incidences of graffiti and removal of drug paraphernalia that had to be dealt with, and 324 medical, intoxication, social assistance, and overdose calls. This is for the week of May 19th to the 26th. On May 11th to the 18th, our total responses were 2,003 incidents, with a cost associated with these services at $75,398. Falling under the same categories in regards to the human waste and debris in encampments is 1,032 incidents, with our graffiti and needles and drug paraphernalia was 120 locations in cleanup. And our intoxication, social assistance, and overdose calls for that particular week was 420 incidents. I share this because of the reason that we continue to see an escalation in our community of the challenges with this particular population. It's also noted that I've also informed the appropriate authorities in regards to we are seeing a huge increase, and I don't know if other communities are seeing this, but copper that is being stolen off of air conditioners. And one incident I think I shared with Chair Henry, in one business, they had 7 air conditioners. The copper had to be replaced, cages put on. The cost to them was $57,000 for the damage that was done. Last night I was informed that one of the facilities on Ritson Road, 8 of their storage units have been broken into, and also copper being removed from many of the outdoor air conditioners. The criminality aspect that is associated with the complexities that our communities are facing is getting more and more problematic. And we're working with, of course, Durham Regional Police, with our social services teams. But what I can tell you, in the early days of the high season, we are seeing a huge increase in regards to incidents, which is concerning. It's very, very concerning, because of the reason that we just don't have the capacity to deal with this. I don't even know if health does, or social services does, or police do. What I can tell you is it's getting to a point where something drastic has to happen. You know, I'll be honest with you, I'm lost. I pulled out my binders yesterday to look at the correspondence, the documentation. I have about 4,000 pages of documentation dealing with this particular file personally. I've had no support of my local MPP for 11 years, and that disappoints me. I've had no support from my local MP, and that's disappointing me. I've had more luck with our MPP that represents the north part of our city and Durham riding in recent days. But my community can't, we don't have the capacity, we don't have the expertise. I don't think the region has the capacity or the expertise in regards to it. And these numbers continue to escalate. I thank the region for your compensation in regards to some of the challenges that we're facing. But that's over $150,000 in 14 days. We're in the millions of dollars of stuff. I just, unless we're able to get the proper care at the proper time, we get the proper supports in regards to not only withdrawal management, but also long-term recovery, which I'm pleased that we hope to be able to announce this hard hub sooner or later once we get all the details worked out that has a housing component to it. I think that that's where the starting point is. But the emergency ward at Lakeridge that is for mental health and addiction has to be activated. I had to excuse myself because there was a call that came in regards to it. The Premier, to be absolutely honest, was surprised that the funding wasn't in place in the last budget. So I take that as an optimistic that maybe he kicks a garbage can and helps us. Maybe that'll help, Madam Chair. I don't know.
So it's interesting, and thank you for raising, especially with the costing, because I don't think across all of our communities we're actually looking at the same breakdown, the same dashboard as well too. And I know that my staff at the town of Whitby have reached out to your staff to have an understanding. But ultimately, it's like it's the who and the what and the how. And with you speak about the graffiti, and our graffiti within our community has just gone through the roof. Who it is, it's potentially, I'm shortly supposed to meet with our inspector, and this is part of the conversation that I'm going to have, because there is a new tag in town, and who does this tag belong to? And I know it's in your community as well too, because I've seen it. But when we meet together as the mayors collectively, it's like it's bringing together that consistent information. and to ensuring that we have like the same information that we're putting out there, because it would, I think it'd be helpful as a whole, because when we're talking about, we're looking at the town of Whitby, we're doing a core services review. And when we're looking at the core services, what really is our purpose as a municipality and what we're supporting in budget? But even with the staffing and what we're being expected to do, I think if we were to break it all down, all of us, like who, and I'd be happy to share and to build with what you have, that value of what we're impacting onto our property tax, but also onto our staffing, they're going over and above. And we're going over and above, which is outside of where we should be moving with this. And you're right, it's like, to have the provincial government to react and to respond, we're going to have to reestablish relationships again with the federal government to look at how this is impacting within our communities. But it needs to be a bigger picture. And I know Ajax, and I don't know 100% what you're collecting with your data, but I don't think it's anywhere close to what we're collecting with our data, because you've only just begun with the data.
Yeah,
with
and
Ajax.
we've got everything GPS, so we've got heat maps. We started this program 2 years ago so that we could actually track it. We knew that the region would want that data in regards to us, our justification for looking at support through the region. So we were very purposeful about creating the software package that goes with this, because we didn't want to speculate. I know that our team is more than willing to be able to share that. We've shared it with Kitchener also. Kitchener came to us and asked us about it, and so we've been very, very forthcoming in regards to sharing the information. But it's very problematic. I don't know. I really don't know what there's. When people call me and say, "So what are you going to do about it?" I no longer, after since 2020, I don't have any more answers for them, except for we'll keep on trying. And I think that's I'm frustrated, but I don't have the answers any longer. And so
When's our next roundtable meeting with the mayors? It's soon, isn't it? Well, that was the only one, but I thought there was another one. Okay. Because I think that if we can take a look at standardizing the approach for ourselves to start, align it to some of the work that's already being done, like the point in time. Like there's a lot of dashboard information that if there's a consistent message and what that looks like, and present that to the Minister of Finance, present that to the Minister of Housing and Social Services as well too. Like look at how like this is outside of what we are expected to do and what we are doing, and this is the value that it's costing us.
I thank you, Madam Chair, for all your suggestions in regards to this issue. The one thing I'll leave this committee with and our members is I've made every mistake that's possible in regards to the complexities of this file. And so I'm more than willing not only to be able to share my failures, but also some of our successes. And one of the things that I will leave as a cautionary tale, that concentrating services is not beneficial to those that are the most vulnerable. And that has been one of the biggest mistakes I've made in my community, that I've allowed that to happen. And what it's happened is it's been the destruction of businesses, residents, safety, and those that are the most vulnerable are being victimized. And so, like I say, I'm more than willing to share my failures and our successes if that would be beneficial. But please take that under consideration. Please do not centralize your services. It has been hugely detrimental in regards to our city. So, thank you, Madam Chair.
I appreciate that. Thank you. Is there any further comments? Chair Henry.
Thank you, Madam Chair. Coming from my previous life a long time ago, there are only a few places that accept copper scrap. And maybe this is something that the Police Services Board, Dan, to be honest, but the chief needs to be aware of, because it's not just happening in this community. I was in Clarington the other day for a doctor's appointment, and they took all of the units off the building. 5 of them, actually. So they can only go to a few places within the Durham region that will accept that stuff. So maybe if we can get to the facilities that receive copper scrap, and you walk in with a handful of copper, and in the old days they used to pay you in cash for your scrap. Maybe there's an easy way to deal with this, and we don't have to think of it as bigger than the fact is if you can get it to where it's being taken, but it has to be done across the province because they'll only take it to another community. But if we can get it to where the scrappers are and get them to help us, because theft is theft. It's like stealing a car. You steal an air conditioner, you steal a car. Same principle. It all goes through our insurance. We all collectively pay for it. But I think there's a simple way to do this, but it'll have to go through the police services. And of course, everyone's aware I don't sit on the board. So.
Councillor Brenner.
I have another item for other business if this topic is
Let
over.
me see if
Thank you.
Councillor Neal, do you want to speak to this item or you have another item?
No, I was going to speak to this item, and our parks, like Memorial Park, there's a lot of copper, and in Whitby, there's copper plaques and everything else that's sitting there. I mentioned it about 10 years ago to the city in regards to that because I knew the value of it, and like that's there. So, I mean, we can do something to protect our parks maybe too because they'll be coming for that. Thank you.
Thank you. Councillor Brenner, do you want to hit your, there you go. Councillor Brenner.
Thank you, Madam Chair. On a different topic, everyone's aware of the tragic homicide that happened in the city of Pickering on Friday. I don't want to get into the details. Obviously, there's a police investigation going on, but I do want to ask through our Commissioner of Social Services, at some point, I know that we are talking about and looking at some type of a community healing to deal with some of the trauma that everyone is feeling from the shock. Will any of our staff from our outreach in terms of social services be part of that? And has there been any dialogue to work with DRPS and anyone else to begin planning for it?
Commissioner?
Through you, Madam Chair, I am not familiar with any planning that's going on or if we've been asked to participate in anything like this. Usually it would be the community that does set it up, and if they're interested, I do have family services staff who could be made available to support, definitely.
Okay, I'll reach offline to
Sure.
you because I know we are talking about it with DRPS as well.
Yeah.
Thank you so much.
You're welcome.
I know the school boards had people in place the very next day.
Yeah.
Yeah. Yeah. And that was very tragic for your community, and my sympathies towards what has taken place. We have no other business. Motion to adjourn. Chair Henry, second. Councillor Dyes. Any opposed? Have a great afternoon, and thanks for the long morning and into the afternoon.